I'll just briefly tell you about myself. I'm a neonatologist working in Oxford, and I'm also the girth lead for neonatology across England, very much involved with quality improvement at a national level. And I just introduced Emma. Do you want to come in and introduce yourself?
Thank you, Larry. Hello, yes, my name's Emma Johnston, and I'm a neonatal parent myself, and most recently the neonatal parent and family engagement lead for the Thames Valley and Wessex Neonatal ODN. Thank you.
Lovely. Just to remind everybody that we will be recording the session. This is partly so that people will be able to come back in and listen to the session, and some of the slides will also be shared. I'd like to give thanks to Eileen for putting this programme together. She's worked really hard on this. This is the inaugural programme for the Oxford and Wessex MatNeo learning event, and I think we've got a really lovely programme looking both at how the perinatal teams are working in various different ways across lots of different parts of the network, but also very importantly including the parent voice and what's being done at a network level and also at a local level with regards to parent involvement in this quality improvement, which is so important, and also how the ambulance service fits in and what they've been doing to try and improve quality of care for mothers and babies. So I think we've got a really exciting morning ahead of us. I'm just going to warn the speakers, because it's such a tight timeline, we'd like to do 10 minutes of talking and ideally 5 minutes to just get a few questions in. It would be really good to try and keep to time as much as possible. So at about 9 minutes, somebody's camera will pop back up, and probably Eileen. And so if you see Eileen's camera pop back onto the screen, then you'll know that you've only got about a minute left to try and wrap up before we ask some questions. And please feel free, everyone, to use the chat function whilst you're going through. We won't be accepting questions on the way through, but I will be taking some hands up at the end to ask a few questions. Okay, so I think without further ado, we are probably going to be starting very soon. Please be aware of the instructions that are currently on the screen at the moment regarding keeping your camera off and yourself muted if you are not speaking. So I think that's really important. So that would be very gratefully received. And we're on to the first speaker, who Lawrence is on the line. Fantastic. So I know Lawrence very well, and I'm sure many of you do. He is a consultant obstetrician in Oxford and is the lead for the Fetal Medicine Centre at OUH. He's also been very instrumental in setting up the AHSN and maternity neonatal network and maternity network primarily, and has worked really, really well across both maternity and neonatal to help with perinatal pathways. He has a very strong interest in patient safety in maternity care, and has done a lot to try and enable safe systems, actually across a variety of different platforms, but particularly looking at how that works across the network. And he's also published very widely on topics around breech and fetal growth particularly, and is an author of a very useful undergraduate textbook. So welcome, Lawrence, and today Lawrence is going to be talking about reducing morbidity without increasing mortality, a challenge to talk to us about in 15 minutes. Thank you, Lawrence.
Thank you very much, Larry, and I'm apologise that this doesn't initially seem relevant to preterm birth, but it is, I promise. Next slide, please. So we all know what's going on in this country, that we're being told we're absolutely terrible, and everybody feels under a great deal of pressure as a result of this. Next slide, please. And what can we actually do to prevent mortality? And I have to admit, it's remarkably little. So we can give people a bit of lifestyle advice, tell them to stop smoking, give them aspirin, occasionally give them progesterone, sort out their gestational diabetes, and very occasionally do some fancy fetal medicine things. But most of those don't really make very much difference. Next slide, please. Ultimately, all the scans, all the tests, and all the risk assessments are to find out the babies for whom we think we should just intervene and deliver them. And this is our major mechanism for preventing mortality. And of course, when we do it, that can affect morbidity. So the question is who and when, and I suppose how as well. Next slide, please. And there are massive trials that have coming out saying this is how and who should be induced or hopefully offered induction. And it seems every week another big, massive randomized controlled trial comes out saying this is another group of people that you should induce. And NICE has joined as well with the original suggestion that if you're of BAME ethnic origin, or if you have a big baby, that you should be induced. So there's quite a bit of pressure, but it's again this business of just simply making sure that you expedite the birth. Next slide, please. And further, Cochrane have even come out and said routine induction of everyone at 37 weeks will reduce perinatal mortality. So there you are. Next slide, please. And surprise, surprise, could you just press the control button on there? I keep seeing who's joining in, coming up in the middle of my screen, but can somebody just press control on that slide? Or the return bar. Okay, so no, go back again, go forward again. So on that slide, you can see if I've drawn a line, but we can't get it to go there, but you can, if you draw a line at 37 weeks, you'll see all that peak on the right will just simply disappear and you won't have any stillbirths beyond that point. And, you know, therefore it's not surprising that routine induction at 37 weeks is going to reduce stillbirth. Next slide, please. There's the line, thank you. And we're convincing ourselves in this country that stillbirth reduction is working, and maybe it is, maybe it isn't. We'll see. Next slide, please. But it has a price. And this graph on the left is the single most important graph in maternity practice. The red line shows the cumulative risk of stillbirths as you go further on in the pregnancy. Remember that it's only 10 per 10,000 when you get to 42 weeks, but that's enough. The blue line, however, is infant deaths. And you will see there that if you deliver everybody at 37 weeks, you will, surprise, surprise, prevent the stillbirths. But you will also subject these babies to an almost doubling of the risk of infant death compared with the baby born at 39 or 40 weeks. On the right, we've got the overall decline in infant mortality in this country since 1980, and you will see that it is flatlined. Next slide, please. And you'll also potentially affect the baby's IQ. So the graph on the left shows that the highest IQ is in babies born at 40, but babies born at 37 have a lower IQ. On the right is the prevalence of special educational needs, and amazingly Saving Babies' Lives too has realized this, and this graph comes straight from there, that you can see it is a log scale on the left, so you've got to be careful of it, but you can see a significant difference in special educational needs in babies born at 37 when compared to 40 or indeed 41. Next slide, please. And cerebral palsy. You've also got more babies born at 37 weeks. They individually have a higher risk of cerebral palsy as well. Next slide. And indeed, in tandem with all these stillbirth initiatives, we have a neonatal unit admission initiative, and ATTAIN. And I put it to you that quite a lot of the problems that we would love to blame on paediatricians or even poor midwives measuring the blood glucoses after babies are born is actually down to the fact that more babies are coming out at 37 than at 39, but because we call them all term, we don't really notice it. Next slide, please. So should we really call 37 weeks term? And I think that's why I've managed to fit this into a meeting on preterm birth, that I think we shouldn't be calling 37 weeks term. Next slide, please. So there's a potential for well-meaning initiatives to do a great deal of harm. Does all this mean that we just wait to 39 weeks and then we induce or offer induction to everyone? But of course, actually, 80% of women are still pregnant when they're 39 weeks. So that's an enormous amount of intervention. And could the NHS actually cope with more inductions? We've all seen the workload issues from induction, meeting MIS, all those sorts of things, the impact on our labour wards. And of course, will women really accept that? And should we be doing it? And at the bottom here is a slightly glib remark that comes from Saving Babies' Lives Too. It's the only acknowledgement that I can find that induction of labour may also increase the workload of the maternity service, which has the potential to impact care of other women. Absolutely right. And that's one of the reasons why I think a number of maternity units are struggling at the moment. Next slide. So we do need to reduce stillbirth, but we do by doing this risk causing death later, and we could make our overall population just a little bit more likely to be disabled or just a little bit less intelligent. Maybe we shouldn't care. We also risk overwhelming our labour ward and causing problems in other parts of our hospital because we're so busy in inducing people. And of course, we do have, as a result, potentially some very, very dissatisfied customers. So that's all extremely gloomy. And I want to share with you a little ray of sunshine, a little bit about what we've been trying to do, and then very briefly onto the national picture. Next slide, please. So many of you will know that 10 years ago, if your obstetricians were told that if the baby was measuring under the 10th centile, you simply had to offer the woman induction at 37 weeks. And we didn't do that. We decided to do a triage system, and this is a slightly less sophisticated version, or actually doesn't really tell you how to do it, is recommended in Saving Babies' Lives Too. But ultimately, you take your small, allegedly small babies, some of which of course aren't small and some of which are small because they were always intended to be small, and you triage them into the higher risk and the lower risk ones. And this paper that I'm showing here showed that they had very much better neonatal and maternal outcomes when we did that than when we followed the standard green top guidelines. And indeed, in Oxford, we've been doing a universal 36-week scan for the last 7 years. And if I just share the data for you for 5 years of that, we had over 1,000 babies meeting the criteria for what ISHUOG would essentially call fetal growth restriction. And among those babies that we have largely managed conservatively, we haven't insisted that they deliver at 37 weeks unless they're particular risk factors. We've had 4 deaths, one of which was in somebody who actually should have been referred to us and wasn't. So it was a system error or human error, but system, I think. And the other 3 were neonatal deaths, 2 of which were unrelated to the problem in the first place. So in a group of very, very high risk babies who should allegedly be delivered at 37 weeks, then those outcomes should be considered pretty good. Next slide, please. This is a very brief sharing of what that protocol involves. And one of the things I've learned in the last few years is that actually any hospital could do this, and quite a lot of hospitals actually are. So there's some quite sophisticated risk stratification, so-called SGA clinics going on in lots of hospitals. And I'm quite happy to share that with you if you like. And then hopefully final slide. Ultimately, the future is going to be about accurately predicting who is at risk and who isn't. So currently, we just simply name a number of risk factors and say that makes you high risk, and you could have 1 risk factor or you could have 10, and it doesn't really distinguish between that. And then, given that we're increasingly labeling every poor woman as high risk, how do we prioritize one high risk against another slightly higher or slightly lower risk? And the future is going to be using all the different independent variables. So we're talking about stillbirth. What you do is you have 10 different independent risks for stillbirth. maternal age, 36-week scan, Doppler here or there. And then instead of using cutoffs of each individual one, you use continuous variables. So you use the actual measure of that. So 45 is higher risk than 41. 35 is higher risk than 31. And then you create a model, and it's really not that difficult mathematically, to give people an individual risk of different adverse outcomes. Now, it is difficult, but we've been doing it for 20 years for Down syndrome. That's exactly what the combined test does. And now we need to do this for adverse pregnancy outcomes. And it's very exciting, for instance, that the Quip app is doing this, albeit on a simplistic basis. And indeed now the Tommy's app is doing this for preeclampsia. And so you'll end up with fewer women being called high risk, but the women who are high risk are more likely to be high risk. And this is definitely the way we need to be going in obstetrics, so that we stop pathologizing it at the same time as identifying the people who really are at genuine risk. So I'll stop there. That's 20 slides in about 7 minutes. So I'm sorry for talking so quickly, but thank you very much for listening.
That was brilliant. Well done for doing that in such a short period of time. You covered a lot of ground and it was really, really clear. Can I just remind everyone to just try and keep their mics off if you're not talking? So I can see a question in the chat, but does anyone want to raise their hands for a question first? Anyone want to ask a question? So someone in the chat has put a comment really about struggling with induction of labour before 39 weeks. So very much advice given around this would be very helpful. Is that the specific advice that you got around that project that you've had going on for a little while? Would that be your key message around that, Lawrence?
Well, I think the first thing is you need to have a very good reason to induce before 39 weeks, certainly before 38, because you are essentially increasing the risks for the child long term. And so I think we should be struggling a bit with induction at that point. But there definitely are some people where the overall risk benefit ratio is better. So, you know, we have a national program on not doing cesarean sections before 39 weeks. The Americans had a national program on not doing inductions before 39 weeks. They called it the 39-week rule. And then lots of people, if they were too simplistic about it, they ended up having more stillbirths, because there are definitely some babies who do need to come out before 39. The question is actually working out who those are. So I think, you know, I'd say to your question of what the indications are, why are you inducing those people? I mean, if they're babies on the first centile with an abnormal CPR, you should be inducing them. But if they're women with mild cholestasis, you definitely shouldn't.
That's really good. And when do you think that the maternity AHSN is going to be adopting anything around? You mentioned the Quip app. Is that something you're thinking of adopting, or has that been discussed across the maternity network?
Yes. Yeah. I mean, the reason to adopt the Quip app is to try and time the steroids better and get people admitted who need to be admitted. But, you know, the Quip app gives you a percentage risk of labour in the next 7 days. And the Quip app website suggests that you admit people if they have a more than 5% risk of delivering in the next 7 days. Now, that's better than what we currently do, but you can see an awful lot of steroids being given unnecessarily there.
Okay.
For instance.
Thank you. That's all right. Has anyone got a final question? Otherwise, I'm going to let Lawrence go and move on to our next speaker. No? Thank you so much, Lawrence. That was great.
My pleasure. Thank you.
Thank you. So without further ado, is Catherine on the call now? Just want to check she's here. Yes, she is. Lovely. So Catherine is very kindly going to speak to us today. She's been working for SCAS for 17 years and joined as an ambulance technician in 2005, so has had an awful lot of experience being a paramedic since 2010. She primarily works as a clinical mentor and team leader at the Reading Resource Centre, and has more recently moved to Reading. Sorry, I've just had somebody's pop up and I can't see anything. Thank you. So she's now the education team manager at Newbury, looking after a team of clinical educators, and she's going to talk to us today about ambulance services as they relate to maternity, and it's called A Fork in the Road. Thank you very much.
Good afternoon, thank you very much. First of all, apologies, Darren Best was supposed to be here today, but unfortunately he was unable to make it. So yeah, this is a presentation called A Fork in the Road, and hopefully it will give you a little bit of understanding about South Central Ambulance Service and how we respond to maternity calls and how we respond and the decisions that are made during that process. Next slide, please. So this image should give you an idea of the areas of SCAS. So we serve Buckinghamshire, Oxfordshire, Berkshire and Hampshire. Those are the areas in yellow. And then we have our patient transport services, which is Surrey, West Sussex and East Sussex. We also support Dorset through a call centre and mutual aid. In the yellow areas that you can see, we have a population of approximately 7 million. And pre-COVID, we had approximately 1.2 million calls to 111 per year. And as an ambulance service, we attend approximately 500,000 calls a year. At the minute, post-COVID, we attend or we get approximately 9,000 to 11,000 calls a day. 40% of our resources are through private providers. They work under our remit, but they are less familiar with our area and they're not governed by us. We have 2 headquarter sites, one in the north, one in the south, and they're multi-site. So if something goes wrong and they're unable to answer the calls, then they're backed up by another site. And the same with, we can be backed up by London or Southwest. Just for a kind of a little fact, during peak COVID times, we ended up taking 20 to 30% of the calls from London because they just couldn't cope with the load that was coming in. So it's not often just our workload, it's other areas as well. So I think it's important to realise that if somebody makes a 999 call, that call could be answered elsewhere in an area that's maybe not familiar with the services or the pathways that we have. So just something for you, oh sorry, next slide please. So just something for you to think about is how many ambulances do you think we put on in a day? And while you have a think about that in your heads, I just kind of wanted to say that we have a fleet of 900 vehicles in South Central Ambulance. That includes all our vehicles that are off the road, that cover transport and our pool cars. So in a single day, in all that area of yellow, we resource 163 ambulances. So it's probably a lot fewer than you may think. To keep our vehicles on the road, we have a dedicated workshop and we have dedicated support services. But also there is nationally a shortage of paramedics and ambulance nurses. We have emergency care assistants, ambulance technicians, ambulance associate practitioners, ambulance nurses, paramedics and specialist paramedics who work within primary care as well. So we have a lot of staff, but we have a lot of shortages as well. Next slide, please. So this slide will hopefully just give you some idea of what happens when a 999 call comes in. So the calls are answered by emergency call takers who are non-clinical, and they read from a script which is based on the responses they get, and this is called pathways. So a whole 999 call should take about 40 seconds, and the call taker should get to around question 5, as you can see on the slide there, in about 10 seconds. And this is to allow them to highlight the really life-threatening kind of obstetric emergencies. And if they tick one of these boxes, then it's confirmed as a category 1 response. Once they get to around question 5, this call will go over to an emergency dispatcher who will dispatch an ambulance to get that there as quickly as possible. As they're going through the rest of the questions, it may take them down different pathways, and the severity of the call may actually change. So it might be downgraded depending on the answers they get. The classification of the call depends on the questions, and it also depends on the answers that that call taker gets. So it can depend who's on the other end of the phone. It could be the mum, it could be the partner, there could be language barriers, there could be, you know, somebody might be very upset and they might just not be able to get that information across. So that can all impact on how and what is dispatched to that call. Next slide, please. So you can see here we have several categories of calls. A category 1 obstetric emergency will get what we call a C1 response, which means that we should dispatch an ambulance and they should arrive, obviously depends on area and how far away they are, within 7 minutes. And that's in line with people who are in cardiac arrest, having seizures or deemed unconscious or choking. If the call goes to what we call category 2, this could be a maternity call or an imminent delivery, then the ambulance is supposed to arrive within 18 minutes. However, the dispatcher may wait approximately 4 minutes before they actually allocate a resource to this, because it might be that it doesn't need that level of resourcing, or it might be that another call may come in which might need a higher response. So a cardiac arrest could come in at that same time and they need to send that ambulance to that role. The ambulance response plan, the ARP, is all about getting the right resources to the right people. So for obstetric emergencies, maternities, we need to get an ambulance to them rather than a car or a community responder. So it's about getting the right people at the right time. Next slide, please. So this slide just sort of highlights a few things that sort of impact on the decision making and people's experiences. So obviously there's lots of human factors, as there is everywhere within the ambulance service. But en route, you might have clinicians and crews thinking about the fact they're going to a maternity job, and that may affect their confidence. It's probably something they don't get very much exposure to. We don't attend a huge amount of maternity calls. They could be worrying that it's complex, and this could obviously cause them stress and anxiety en route. You might also find, in very rare occasions, they might get a non-clinical attending as a first response. So these people may have had even less exposure, and particularly with dealing with these complex cases. When they get on scene, they'll obviously use an ABCDE approach to identify any kind of risks. But as we know, maternity jobs can be quite complex, and again, it's not something we deal with every day. They may not be really confident in interpreting the results of all their observations, particularly in terms of circulation and maternal physiology. So they may not necessarily identify those kind of risk factors or small variations in those observations. We do have guidelines. We have our JR Calc, which is our national guidelines, but again, they are national rather than local. So they don't always help people to make decisions, particularly around transport and the areas that they should go. Crews will use a medical model, so hopefully they'll be asking good questions and getting good answers to get a good history from that individual, and that should again help them to get the right decisions for that right individual. However, again, experience and exposure to these types of jobs can be limited, and also using maternity notes, which can be quite complex and again sometimes for us difficult to understand due to terminology, can impact on those decisions and how people are interpreting the events. Next slide, please. So some other factors here that might impact on the job. So as with everybody, we do long shifts, often 12 hours, and particularly when we're thinking about where we're going to transport these mums, we may sort of be thinking about what we call the path of least resistance. So if we have a hospital that is consultant-led, which is 100 miles away, compared to a midwife-led unit 10 miles away, we may be thinking we'd rather go to a more local area. And again, that comes in with the risk. If we have to transport someone 100 miles and we're with them for that whole period of time, we may feel more comfortable and safer going to something that's a lot closer. For us, doctors, midwives, you're all the same, you're all expert care compared to our level of knowledge and experience. We are learning around this. We have a lot of work around major trauma, and we're now learning that, you know, going further afield can actually benefit the patients and their outcome rather than taking them to somewhere closer. However, we haven't got the obstetric pathways in place yet for this, but that may help us in the future. Other things we know is that patients move, they go on holiday, they go to visit their friends, their family, and the system can fall down. We don't necessarily have access to resources outside of our area. We might not have their paperwork or their records, and sometimes taking a patient home or to their hospital outside of our area is not something that we can do, unfortunately, because we have such limited resources. We have to stay in area. As we said, maternity notes can be quite complex, and also they contain lots of phone numbers, but sometimes there's not that resilience there if it's out of hours or weekends, that kind of thing. Our resourcing, like we said, we're very short on staff, so sometimes a few years ago I would have been the only clinician on a night shift, so that tells you in a whole county, so we're very limited, and we will be questioned if we're going elsewhere. Again, sometimes we get people doing the right thing, going to the right location, but there can be confusion from the staff, the midwives, or the doctors actually on scene as to whether they can accept that individual or not. Almost there, last slide. So if I could have the next one, please. Yeah, so our learning. So from all of this, we are improving our infrastructure. We now have digital notes within the ambulance service. We can access some patient records. We have apps which are GDPR protected. It allows us to access different pathways, teams, hospital numbers, so that can be really, really useful. SCAS itself only takes 40% of patients to hospital, which is really good. And we also have midwives in our call centres now, so we can phone them up and ask for advice about what to do if we've got complex cases and mothers. One thing that we know that makes a big difference is if patients remain locally, and especially if they keep their information on them. Something that's been sort of shared is if a patient had an app with access to their information that they kept with them at all times, that would be extremely useful for us. Our education is improving all the time. All new paramedics are now degree educated, and we do CPD courses. For example, in SCAS, we have the pre-hospital and obstetric neonatal emergency course, that's the phone course, where we work with the Royal Berks and soon to be Oxford as well. And we do courses, paramedics and midwives together to share learning. I think the main sort of bit to summarise is just that there's always different decisions, and at every step the pathway can change for us, and exposure is a big thing. So there you go. Thank you very much.
Thank you very much for that talk. It's really interesting to hear the perspective of the ambulance service, which I think is an important bit that we often don't really realise, and I really appreciate what you're saying about ambulance crews. There's not happening that often, and it's quite a scary thing to happen when you're feeling less comfortable. So do we have any questions around this? Yes, Peter.
Hi there, thanks for your talk. I was just interested in what you said at the very end there, which is that there's a telephone triage course. Is it for neonates and maternity? And it comes from Royal Berks. And I'm going to find out how to get on that if you can.
No, so it's not. Sorry, it's called the phone course, but that's just the shortening of it. So it's a course we actually run between midwives and paramedics, and we run it out of Newbury Education Centre, and we work together. So it's rather than a telephone triage, it's just the name of it, unfortunately, is phone.
Okay.
Sorry.
Thanks. Cheers.
Thank you very much, Catherine. That was really helpful. I'm going to move us on to the next talk now, which is going to be given by Emma, who has a very interesting background, I think. So originally started off training as an aerospace engineer, and then a business degree and doing marketing as a postgrad. And then had a maternity experience herself, which was very sad, and she may well say something around that. But that has changed her course, and she's very passionate about helping to improve experiences in maternity and to help other service users in maternity. So she's going to be talking today about some of the work that she's done. She's very heavily involved with the Thames Valley and Wessex Neonatal ODN, and developing the Parent Advisory Board and has got a lot to tell us, I think, about how to link in the family users into the work that we do, and particularly around the quality improvement. So thanks very much, Emma.
Thank you, Larry. Can I have the first slide, please? Skip to the next one. Thank you. Many of you have seen me speak, and I wanted to take this opportunity, I think, to put the optimization into more parent terms. I wanted to start this presentation by referring to the Neonatal Critical Care Review Plan, the particular part enhancing the experience of families. So as evidence show, high quality neonatal care must include a substantive role for parents in the care of their baby. In this respect, neonatal care differs from many branches of inpatient medicine. Parents are not bystanders as illness develops and resolves, but perform an active role as a member of the care team. So to perform this role, and in order to minimise morbidity, parents require support and facilitation by a service that has appropriately focused and trained nursing or AHP staff working alongside medical and nursing clinical practice staff. So I really am talking about everyone linking in with this parent voice. Next slide, please. So I've just popped on, I don't know how often you've heard the term co-production, but I like these ways of just demonstrating it. It really shows on the right hand side with the graphs that it might seem easier not to reach out for those voices and taking it that stage further and actually co-creating with the parents, but it actually in the long run saves a huge amount of time. And I love this a circle that explains that this is a constant feedback cycle. We can only maintain hearing this voice if we continue to say what we've done as a result of hearing that voice. Next slide, please. Thank you. So I love this. So I just wanted to leave this as something in your mind. Why is co-production important? I always hold on to this quote that I've heard. If you want to check if the shoe fits, don't ask the manufacturer or the shoe shop, rather ask the person who's wearing them. So yeah, the lovely parents, they're putting up their lovely mobile thinking that's just what their baby wants, and their baby is seeing their bottoms. So yeah, please take that with you. Next slide, please. So I've popped on something which many of you might have seen through your studies. I certainly did a lot, looking at parents, but also staff needs and what they are. And I love Maslow's hierarchy of needs, looking from those basic needs, the psychological needs, and those self-fulfillment needs. So how can we fulfill these needs in enhancing the experiences for families? And also, how do we involve the people doing the jobs in this piece of transformation in enabling buy-in to this new culture and way of working? So that second point that I raised, it's so important that it's done at every level and that there's buy-in at every level. And regarding the families, this is the opportunity to really ask and really listen. Next slide, please. Now, I found this, which I found it was a bit fun, I suppose, but it really helped me express the postnatal mental health aspect of a parent's journey. And there's a lovely quote there from Hannah. I remember coming into the hospital one morning and going into the nursery, and he wasn't there. A different baby was in his bed space, and it just felt like my heart stopped and my stomach was in my mouth. They'd moved him to the next nursery along the corridor, but didn't ring me to make it a positive move. So it would wait. Sorry, didn't ring me as it was a positive move. So it could wait until they could tell me in person. I just picked out something which a lot of kids follow regarding emotions, and just wanted you to think about that quote alongside, say, the top sadness, and then adding that along with the sinus along the left hand side, and you can see that's getting closer to despair. So it's really thinking about how parents are thinking, feeling, and how can we minimize those feelings and not add to those feelings in how we go about involving them in their baby's care. Thank you. Next slide, please. So in the first year since I reached out, I suppose it embraces all of what I've said in the previous slides. Lovely Gina, the lead for the Thames Valley and Wessex ODM, reached out to me right back in June 2020. I looked that up and I couldn't believe it, with a vision of a parent role within the network and for forming a group of neonatal parents in a safe way to assist the network in hearing the parent voice in the work there was to come. So little did we know then that we would have achieved so much with the parent voice truly embedded. So this is just a slide to show you that together we recruited 16 lovely parent representatives to the Thames Valley and Wessex Parent Advisory Group. We have one dad, non-birthing partner, that's part of our group. And it's really a privilege to be part of it. They dedicate their time to helping with transformation, and it's a very supported group as well. Already the PAG sit on clinical forums, governance boards, preceptorship education programme we are part of, and I've spoken on a couple of times along with other parents, family integrated care working group, and the neonatal postnatal mental health group. And I've also had the privilege of being able to help create job descriptions for our lead care coordinators and our local care coordinators, as well as a network clinical psychologist, where I sat in those interviews to ask some questions about the parent experience. Next slide, please. So already we are doing an helping to understand parent psychological needs and how best to meet these. The impact of staff support on parent self-efficacy, the education of staff, like I mentioned. We've mapped routes of support for signposting parents. We've got a huge working document that will keep developing, and we're helping building resources, siblings projects, leaflets. We are part of the Parent Passport Working Group, the FI Care Working Group, and as I mentioned, the Postnatal Mental Health Working Group. Most recently, we took part in a focus group for the repatriation project, which involved a half-an-hour listening clinic, working with VCreating in creating a national animation to help other parents regarding repatriation. There's also a role that we're looking to trial within repatriation. So we've been involved in so much already, and that's just some of our work that you can see on that slide. So we've got this amazing opportunity to empower parents and look at how we can create consistency through our units, so that when the unit is needed for what it is intended for, to transfer parents with their babies as their babies are well enough to do so, that there is consistency for that parent, and not everything about what they've just learned changes and they have to start all over again. It's what do we need to look after these parents so that the whole family can have the best possible outcomes. Next slide, please. And I've popped these down, and these are just some suggestions. This list can go on, but what can we do to assess the best possible outcomes for these babies? So concepts that we are looking at the moment is the delivery room cuddles. Having a baby removed immediately at birth is hugely traumatic and detrimental to parents. That first look and first touch should never be taken away wherever possible. Skin to skin, we're empowering parents, we're making them feel like parents, and it's helping with milk as well, and it's helping with that first bond. Parent-led ward rounds. This is something we're seeing more and more of. So we're empowering parents to feel part of the team, looking after their baby, which is a huge asset. I'm really sorry, I keep getting the people coming into the room popping up. Sorry, can we go back? Thank you. Yeah, empowering the parents to be part of the team. They have the ability to watch their baby 24/7. So they really are an asset to the team. It ensures that they remain informed and part of the discussions being made about their baby. I can see Eileen, so I'm going to go through a little bit quicker. The baby's cares, your grandparents' confidence, looking at the way that we communicate, just reframing so they are always the parent. My lovely nurse used to say, I'm going to look after my baby now, which I thought was lovely, but when I reflected later on, I found it very hard. And also parent education, teaching parents how to look after their babies, and parent support can be a huge thing, which we're finding out through the PAG, supporting one another. Next slide, please. Very quickly, I've picked out this 5-care model of change because I do like to see things in diagram format, and it doesn't just look at the 5 pillars of 5-care. But what I want to get you just to look at is actually the outcomes, and that through this presentation we're hearing you know, about the best outcomes for the baby in medical terms. But if I can show you in the outcomes, the confidence and the satisfaction with care is really increased for parents, but also the satisfaction in nursing and medical staff. And also the costs direct to the hospital and indirect society costs are dramatically reduced. So we've all been hearing more and more about a family integrated care, and it's really about information sharing, that parent support, and that parent education. And what can we do in our day-to-day work to make these changes? If I could ask you to think about when you return to your jobs, is there one thing you can do to make your parents feel more involved in their baby's care? And last slide, please. In true co-production style, none of what I've talked about is purely my work, but that's a great ODN team willing to listen and learn, and our amazing neonatal parents that give up their time to support us and ensure we really know what they needed at the time. If I could just ask you again to take one thing from my presentation back to your units, that's all neonatal parents asks. Thank you so much for listening.
Thank you, Emma. That's a great talk. And thank you so much for going through all the work that you've managed to do in the last couple of years. That sounds like a huge task, and I'm sure that that will have sort of a ripple effect across all of the units now that you've got that really well set up across the network. We're running a little short of time, so if there's one question, I'm happy to take it. Otherwise, I'm going to move this on. Anyone particularly keen to ask Emma a question? Okay, thank you so much, Emma. That was fantastic. So in the spirit of keeping things moving and making sure that we now move on much more to focus around some of the preterm work, I'm welcoming back Charles, who previously worked in Oxford but is now a consultant neonatologist in Southmead. He has an extensive research interest, particularly around physiology around the time of birth, particularly newborn resuscitation research, and also looking at non-invasive ventilation in the preterm infant. So he's done extensive research in this area and is going to give us an excellent and update around what's happening around ventilation on the uncut cord. So thanks very much, Charles.
Thanks very much, Larry, and thanks very much, Eileen and team, for inviting me. I do apologize for not being in a very quiet office. I'm in a public space. That's I can't help it. Sorry. The first question that I pose to the audience should come at the start of this talk. Is the interactive question there? On the next slide, maybe.
I'm just going to
No?
get it up. Hold on. I will send it in the
That's all
poll.
right.
Sorry. Hold on.
That's absolutely fine. So the question I would like to ask the audience is whether or not you think that ventilating babies on the uncut cord is currently state-of-the-art recommendation by major bodies like BAPM or the Neonatal Life Support course. In the interest of time, I know we've had great talks and we know other people are also in line to give more and very exciting data. I would like to progress on this, and maybe we go to my second slide, which gives you the answer to that question. So here is an example of two international guidances who are based on your screen left-hand publication by the Neonatal Task Force from ILCOR, which is a very well-funded collaboration of people who are doing nothing but systematic reviews of clinically important questions, in this case on resuscitation research. And they've come to the conclusion that at this moment in time, when they wrote their guidance and published it in 2020, just a little click, please, that there was no suggestion for ventilating babies whilst they're on the cord. And I'll like to take the next 10, 12 minutes to take you through the evidence for this. Next slide, please. The NLS, the European Resuscitation Council Neonatal Life Support, which is the basis of NLS courses which we do here in the UK, has updated its guidance only in October last year. It has a very clear statement towards delaying cord clamping, especially in the preterm infant, for the very many hematological and circulatory benefits that delaying cord clamping has. Next slide, please. So it's recommended, and I'm sure this is common knowledge, that a minimum of 60 seconds should be used in infants not requiring resuscitation, and that sometimes in stable infants this can be exceeded. There is a statement to cord milking, which is another form of delaying cord clamping or helping blood go from placenta to baby, which is reserved for babies of greater than 28 weeks. Next slide, please. Let's just remind ourselves of the circulatory specifics of a baby undergoing the transition from being a fetus to being a newborn. Looking at the two graphs on the right-hand side of the slide, the middle bit shows the fetal circulation with the placenta intact. The lungs are blued out, which means the lung perfusion is only minimal during in the fetal life in pregnancy. But there are significant changes as soon as the baby is born, and particularly as soon as the placenta is detached. So we can characterize different phenotypes of circulation. One is the fetal, the other is transitional, and the third is the newborn or adult, which you see on the right-hand side, which clearly involves the lungs and separate circulation for pulmonary and systemic circulation. The heart has to work much harder once the placenta is detached, and systemic vascular resistance increases and pulmonary blood flow increases. So there's a lot of challenge in terms of pre-load and afterload issues for the compartments of the heart. Next slide, please. So the concept of delaying cord clamping for bringing blood from the placenta to the baby is far from new. The scientific interest of this goes back as far as immediate cord clamping has been established, and Yeo and others in 1974 have already challenged the concept of immediate cord clamping. The simple cartoon illustrates how waiting for maybe a minute, as they postulated, will allow some blood from the placenta to re-enter the baby's circulation. Next slide, please. And again, a very simple illustration how waiting a number of minutes here on the x-axis will allow the placenta to empty to some degree to the baby. And whilst it's not a true emptying of the placenta, and we now know it's more about redistribution of blood volume, this graph speaks more than 1,000 numbers. Next slide, please. The numbers which we might want to bear in mind is that the fetal and placental unit bears about 110 to 115 mils per kilo throughout gestation, but whilst the term-born infant carries 2/3 of the blood volume and 1/3 remains in the placenta. And you know, blood goes around and around. A 30-week fetus carries half its blood volume and half of it is in the placenta. So there's a very clear gestational divide on the proportionalism of blood in the different compartments. New slide, please. So the benefits for the extreme preterm or the very preterm infants may be or have been shown to be higher when it comes to delaying cord clamping than for the term-born infants, although the netto effect of better hematological and cardiovascular stability holds true for both. Fogarty et al. Have summarized all the trials in immediate versus delayed cord clamping for preterm infants. And I have, as all of you familiar with forest plots, looking at the little black diamond at the lower end of the graph, can clearly see that the summary of the medians of all these studies declares that if you look at one outcome only, and that is infant survival, it's much better in a delayed cord clamping setting. Next slide, please. The authors just went to the great length of rubbing it in our face that we should have known this as early as 2015, but it took till 2019 to get the full result of this largest trial, the APTS trial at the very bottom of the lower graph, which also shows a very clear verdict for survival. Next slide, please. So I think we can establish and agree that delaying cord clamping is the right thing. Sadly, we're currently in a situation where we advocate time-based cord clamping. We allude to the 60-second rule. Wouldn't it be much more true to the individuality of the babies to look at the baby when it's right, which is now called physiology-based cord clamping? And I'll take you through some of the data in the next couple of slides. Next slide, please. So very briefly, immediate cord clamping here in an animal experiment where a little fetal lamb is instrumented and we can measure the fetal heart rate, the fetal cerebral O2 saturations and the fetal peripheral saturations. Here in the colors orange, green, and red, reacts very differently when it's being managed with immediate cord clamping than delayed cord clamping. With the next slide, I show you the very, very marked changes in the physiology of immediate cord clamping with a drop in peripheral saturation, with a drop in cerebral saturation of over 50% from baseline, and a very erratic heart rate, which only stabilizes at a certainly more tachycardic level than in fetal life. Next slide, please. Take a similarly instrumented and managed baby lamb at birth, but allow it to breathe before you clamp the cord, then you get, by and large, very nice and clean physiological stability. And that's what you want to see if you want to avoid major brain hemorrhage, if you avoid major pulmonary hemorrhage, if you want to avoid swings in blood pressure and in mesenteric blood flow, which might give you necrotizing enterocolitis, etc. So it can be postulated from these animal experiments that physiologically based cord clamping is the right thing to do. Next slide, please. So whilst this is conceived as very, very convincing, there are very, very many open questions how to facilitate this in the human being. The main question which I want to address today is whether we should be giving respiratory support during delaying cord clamping, awaiting the physiology-based cord clamping. Should we resuscitate on the cord, and how are the team and practical aspects? Next slide, please. So the technical aspects first. David Hutchin and colleagues have done a lot of thinking and went into great development efforts to come up with the LifeStart trolley, which is shown in the next slide. Some units may already be using it. It's a little device which, next slide, please. Next slide, please. Can be placed right next to the baby, whether it's a vaginal or a cesarean section. Next slide, please. Go through these rather quickly. Here's an illustration with a mannequin, how the baby can be stabilized next to the baby. I'm currently in Amsterdam, where I work with the developers of the Concord Neonatal, which, as you can see, is a portable issue. Here's Eileen.dudley, the developer, where this device can be used to stabilize babies right by the mother's abdomen, even in the operation theater at cesarean sections. So this is clearly the future for managing babies at birth, particularly preterm babies. And I'll take you to a few studies with these devices. Next slide, please. Before I do this, though, I illustrate the need. This is what we used to do in Oxford, where we, as the neonatal team, went straight into the obstetric field and we started stabilizing the babies by the bedside. And these pictures, shown with permission from the mother and the team, clearly show that if you want to delay cord clamping and serve the baby well in terms of temperature management, you're meeting a lot of challenges. Next slide, please. So, next slide, please. Selected studies on topic, and I only chose a few in the interest of time. One from term-born infants, studied by Dr. Andersson from Sweden, who has a study center in Nepal, looked at whether infants needing resuscitation, so not just stabilization, but true ventilation, should be managed with delayed cord clamping or immediate cord clamping. Next slide, please. The study encompassed 100 babies in each group. And as you can see by just eyeballing the figures here, in blue, early cord clamping, and in green, delayed cord clamping, some parameters were significantly different. For instance, lower APGAR scores at 5 minutes, lower pulse oximetry at 5 minutes, and lower pulse oximetry at 10 minutes, and a lower admission temperature on admission to NICU in the blue bars, which are those subjected to immediate cord clamping. Mortality was also higher. Next slide, please. Anup Kataria summarized the evidence in this slide, where he showed in pink infants managed with delayed cord clamping, and in blue infants with just routine cord clamping. And he showed that the pink managed babies have slightly better values in outcomes, but by and large, not really convincing. Next slide, please. Next slide, please. Next slide, please. Ronnie Knoll, a collaborator from TEPAS here in Amsterdam, did a large non-inferiority trial comparing physiology-based cord clamping with routine delayed cord clamping. And he found that even in very preterm infants, the outcomes were not worse, at least as effective as standard delayed cord clamping. So again, point in favor. Next slide, please. Folkley et al., investigating a group of infants with umbilical hernias, looked at whether delayed cord clamping with respiratory support can be facilitated in this high-risk group of patients. This publication also shows a very nice illustration of the team setup during facilitated delayed physiological-based cord clamping. The findings were not as exciting. Next slide, please. Whilst they could show that there were no major maternal or infant safety outcomes, next slide, please. The group of those infants receiving physiological-based cord clamping and ventilation on the cord, next slide, please, had only marginal benefits, as seen as the first hemoglobin on admission and mean arterial blood pressure. Just a little click, please, to highlight the two significant findings. Thank you. Next slide, please. We're coming to the end in the interest of time. A very brief word of caution of supporting breathing during transition with masks. Next slide, please. The face has got the trigeminal nerve, which, as you know, has got 3 different branches, all of which encompass the lower, the upper lip, and the nose. And if you put a mask, next slide, please, on the baby's face, you are likely in about 30% of babies to elicit the trigeminocardic reflex, which induces apnea and bradycardia. Next slide, please. Another thing that we're particularly bad about is choosing the right masks, and we don't often serve the baby well by having the too big a mask to support its breathing. Next slide, please. Next slide, please. The last slide before my summary slide shows the different baby aspects and doctor aspects in getting respiratory support at birth wrong. Doctors are very good at doing respiratory support badly. We put the mask on the face, we got mask leak, we put too much pressure on, the baby doesn't get any air or pressure. The baby is naughty and just closes his glottis and goes in a strop, or doesn't want to breathe for other reasons. Or the baby breathes, and we as physicians and doctors and midwives, we try to synchronize, and we're really bad, and we just interfere. So doing respiratory support at any stage in newborn life, but particularly during transition, is really badly done, sorry. Next slide, please. My concluding summary is that delaying cord clamping is a good thing. Next slide. We know from good experience that we are great at doing it badly, and we're good at trying to be better, and that's what this group has shown before. I'm convinced that the physiological-based cord clamping is better than time-based. Next slide, please. But whilst it ensures greater stability, next click, please. And it is feasible and probably safe and not inferior to routine care. We are still awaiting the trials that have really shown superiority, and until that data is out there, the guidelines will not change, and we are waiting for this data to give you confidence that if you want to support babies breathing on the cord, then you're doing the right thing. Thank you.
Thank you very much, Charles. That was great. You got through a lot of information in quite a short period of time there. And thank you. I appreciate you're not even in the country at the moment. So thank you very much for keeping your area quite quiet in the place that you're in at the moment. Lots of people applauding. Thank you very much. Have we got any questions for Charles, please?
Hello, there's a question in the chat from Claire. Claire, do you want to ask it yourself? So, okay. So
yeah, sorry, I was just.
Okay, go ahead. Go ahead.
Hi, Charles. I just wanted to ask about delayed cord clamping when when a mother's had a general anaesthetic for instance, an emergency section, whether the benefits of delayed cord clamping outweigh the very small risk of the general anaesthetic being passed through to the baby during those 60 seconds or so.
Yeah, no, I would clearly say yes to that, and it's been shown in trials that it's safe and can be facilitated. Yes.
Brilliant, that's really helpful. Thank you.
Any other questions? I might ask you one myself if there's no others coming up. Charles, you've mentioned that we need some good trials. Are there some already in progress?
Thank you, Hilary, and that's a good question. Yes, there are some good ones in progress. There's the Neo-Duck trial from Melbourne, which has been presented in abstract form. But I wrote to the authors for the sake of this presentation, but they weren't allowed to share any data. But I can tell you that much, it's not totally convincing. And there's other trials which we are still awaiting the results from. So I think we take it on a grain of salt for this moment.
Thank you. That's really useful. And I think it's a really important message to people. Certainly going around doing the GAV visits, people sometimes don't start doing the delayed cord clamping because they feel they need to have resuscitation equipment and ability to give resuscitation support during the delayed cord clamping. And I think the information that you've given today very clearly suggests that people should do the simple stuff and just do the delayed cord clamping. Albeit it sounds like going physiological would be a really good way to go, but at least to start doing delayed cord clamping across the board, don't worry about the kit too much. I think that's
Absolutely.
a really important message you brought across today. Thank you so much, Charles. Thank you for giving us your time. Thank you. Bye-bye. So, last but not least before this morning is Anda. So Anda works in Oxford, and a rather beautiful picture of her, and she still looks like that now. Anda was born and raised in Latvia and initially trained in adults as an adult nurse, and then did neonatal training in a neonatal sort of equivalent level 2 unit. And she's also worked in several other countries before coming to us and being absolutely marvellous in the unit in Oxford. She has developed as an ANMP and has continued to sort of work and train is now on the registrar rota and supporting the transport service as well. And she is the clinical audit lead for us, and particularly for the Maternal SIP project, particularly looking at some of these issues around delayed cord clamping and early preterm optimization. So thank you very much, Anda. You put a lot of work into this, and I'm really looking forward to hearing what's been happening.
Great, thank you so much. So thanks for the introduction, Larry. Can we have a next slide, please? So I'll be talking about the integrating evidence into clinical practice across our network. And Charles already covered a lot of physiology, so thank you, Charles. I don't have to go into depth about that as well. So this is where we based a Thames Valley network in a broad aspect of the England and slightly more small aspect. Thames Valley network in the center, we have Oxford, which is a level 3 neonatal unit, and we have other 4 neonatal units, 5 neonatal units attached to us. So Stoke Mandeville, Milton Keynes, Wexham Park, and Frimley. Frimley is part of our network for the Maternal Safety Improvement Programme, and Royal Berkshire Hospital. Can I have a next slide, please? And so we're going to talk about why delayed cord clamping is important, how we have done it, and where are we now and where are we going. Next slide, please. And so why, again, next slide, is evidence already was provided by Charles, but really to reiterate this is that it reduces the mortality and morbidity for preterm babies. And it is further supported by the BAPAM and NNAP tools, and keeps popping up. And also further evidence by Cochrane review saying that by delaying cord clamping, it reduces the need for the blood transfusions, may reduce the needs of intraventricular hemorrhage, periventricular leukomalacia, and late onset sepsis. And further meta-analysis by Yassani in 2021 showed that when we compare immediate cord clamping, delayed cord clamping was associated with the better odds of mortality, lower odds of mortality in preterm babies. And when we compare immediate cord clamping with delayed cord clamping and umbilical cord milking, it was associated with reduced IVH and the need for red cell transfusions. And there was no significant difference between umbilical cord milking and delayed cord clamping for any outcomes. And similarly, analysis by Sedler also showed similar findings. Can I have a next slide, please? These slides you will be able to access and you can read in your own time. I won't go through the next 3 slides because it just really covers the physiology what Charles already talked to, and because of the timing we'll just skip this slide, next slide, and one after. So James, can we next one and next one? Thank you. So we have further drivers from the organizations such as BAPAM and NNAP and National Patient Safety Improvement Programme, which I'm working part of. And as aim for the Maternal SIP is that we want to increase the babies to receive delayed cord clamping for 60 seconds as a minimum, up to 95% by the year 2025. Please can I have the next slide? And so if we need to know where our network is or was in 2020 and why we started this kind of broader project, is that actually when we're looking at, we have a really broad variability across our network, varying from 11% of babies receiving delayed cord clamping to about 54%. So then when we put in combined where our network was sitting was at 26%. And looking at the data, we thought we really don't do any justice for these babies, that we should improve and make them slightly better if we can. And particularly delayed cord clamping is a cost-effective measure and doesn't cost us at all, just really time and education. Next slide, please. So how we've done it. So next one. We used, Eileen had got us a lovely group together, and in each hospital we had a representation from each of the neonatal, maternity and obstetric teams, and we're working together and to drive the project. And we called ourselves as a task and finish group, and we meet up monthly to update each other, catch up and support, and have a general Q&A session. And each team selects and recruits their OCM champions that highlights and helps the driving the project on day-to-day basis. And really, it is a hard work for all of us. Next slide, please. And tools that support our quality improvement project was giving lectures by ourselves, so myself, Eileen and Michelle, and also using the NHS improvements online resources about the QI methodology and following through the stepwise as well. And also we're using a live QI platform that is a web-based platform that we can register our projects and we can develop the driver diagrams and PDSA cycles and really score our project as to where we're going. The beauty of that is that each of our local units can register the project and we invite each other, and therefore we can see where each other unit is and where the data is sitting. So instead of me emailing monthly getting a data, I can log in live QI and see how Reading is doing or how Milton Keynes is doing, and vice versa, they can see how Oxford is doing. Next slide, please. So based on a QI methodology, I sort of designed the roadmap, how we should process and proceed with the OCM. And this is a snapshot of where we were in June 2021. And I designed this as such how we would run in Oxford in a kind of a systematic manner, stepwise manner, and then we implemented this across the network. And initially we would have a cell idea and get some OCM champions in place, get MDT together and brainstorm. We wanted to know where our baseline data is for each unit and share the data to know where everyone is. Education and awareness is a big part, as well as a simulation, because if we don't explain to people what they need to do, and if we don't simulate in a safe environment, people are not going to understand why this is important. So that's education and simulation is a big part, as well as writing a guideline. That takes a long time. And then furthermore, then register with the local QI hub or live QI system. And being present in introduction phase is also really important, because you're going to be there answering all the questions what team has. And then collect your data and review your data weekly is also important. And then once you are established in your QI progress, then you can do that monthly. And then review with the PDSA cycles. So plan, do, study, and assess cycles that you then implement in a practice. And you can either find that this something is not working or something is working, and therefore you can implement that in a practice. And importantly is to celebrate with your colleagues your success. You know, where is your data sitting? How many babies achieved delayed cord clamping? And for those who didn't, can we learn something about that? You know, be sort of like an investigator of what happened in a non-threatening way. Go and talk to the colleagues and understand, is there education or is there resource needs, and why the baby didn't undergo delayed cord clamping. And then once we all have gone through all that stage, then is the completing sustainability tool and closing up the project and writing up for publication, if all is well. And you can see with arrows indicating back in June last year where each of the hospitals were, and everyone is kind of following each other's footsteps. Next slide, please. So where are we now? So let's move on. So this is where we are. So I think everyone has worked super hard across the network to achieve these numbers. And if you remember previously, our lowest number was 11%. Now we don't see those. So we're ranging from in the last sort of like 4 months, from September to December 2021, you can see that we have 45 to 87%. So babies receiving delayed cord clamping, and that is really amazing. And it's credit to each and every neonatal unit, midwifery and obstetric team working together and providing this environment for the neonate to undergo this crucial transition whilst being born. Next slide, please. When we're looking at the wider context as to, you know, where we are comparing within other units, because we can see just our network, but it's always nice to see where in a broader context where we are. And again, we can see that within the Thames Valley and Wessex network, we're sitting above the 40% margin. So that is very good as well. Next slide, please. And then I wanted to summarize furthermore is as to where the Thames Valley and separate Thames Valley and Wessex network. And we can see that our network has gone up from 26% to 60%. And yeah, I'm super proud of every unit. They've done an amazing job to bring our numbers up. So, and it really improves the outcome for the babies as well. And it also improves the staff morale because we're doing something that's helping the babies, and that's what we're there for. Next slide, please. So where are we going next? So we're going to 95% by hopefully 2025. And I mean, I'm putting a shorter margin by keep extending by each year. We want to move on to the more physiological-based cord clamping, and to facilitate that, we started this in Oxford in September 2021, and I'm hoping to disseminate this across the network by using a portable nasal high flow to support babies' respiration during the breathing. So not resuscitation, but more of a stabilization and enabling babies to breathe and oxygenate their lungs slightly better. And then once we've done that, to facilitate birthday cuddles for all of the babies, either they are ventilated, or if they're not ventilated, on high flow or CPAP. We're a high flow center, so we would use more high flow, but also face mask CPAP if that is a choice of the practitioner if we don't have the high flow available. And a guideline in place is in Oxford, and we just on a Tuesday run a sim with the midwifery colleagues. We had a great attendance, and hopefully the word will spread, and we'll be able to provide this for each and every baby during the settings, either in a delivery room or in theatre settings. But more education is required, and more simulation training is required to facilitate this change of practice and change of the mindsets for the medical team to provide the stability for the neonate. And I think that's me done. Thank you very much. Any questions?
Thank you so much, Anda. I think we need to bottle your enthusiasm and spread it on top of everybody. You've done a fantastic job. Thank you so much. It was really good to hear about that. And I think it's also testament to everyone that's working on those projects in all the hospitals. You've really shown what can be done. It's very much a hearts and minds project, this, isn't it? And you've really made this work. And I think it will be fantastic. So someone has asked where you've got the data from for other trusts, which I think
so
probably
data was provided by Jackie Bobby, and it's part of the it's on a Thames Valley Wessex NHS Future platform. It's available there, and she sort of divided data a little bit more for me, but every there is the late cord clamping dashboard on that website, isn't it, Eileen?
Yes, so so Jackie Bobby is the ODN data analyst, and she's a critical person for us in helping us to retrieve the data. But I would say that there are some problems with the data, and we recognize that. So with our group of improvers, each of the units double checks their own data against the data that's available on the NHS Futures platform. There's a couple of other questions in there. One is about from Joe Sullivan asking, is there any evidence relifting the baby to be seen over the drape during a C-section when DCC is ongoing? And Joe's thinking about the extra impact from gravity. Do we know if this impacts the success of the DCC?
I think as far as reading the evidence, to suggest lifting the baby too high, it shouldn't be done. So if we lift the preterm baby above the drapes, the gravity would not going to work as well from the placental transfusion to the neonate. The evidence that has been said that baby should be at the level of the placenta or within kind of 20-30 centimeters above, but not higher than that, to provide the placental transfusion. So the obstetrics, if it's a C-section setting, the obstetrics can lower the drape down and lift the baby slightly, but it shouldn't go more than 20-30 centimeters above, because the preterm baby takes slightly longer to transition from the placental transfusion to the normal circulation than a term baby. So that would be my answer to that question. Was there anything else?
There are no more questions in the chat. If anybody wants to raise their hands, go ahead.
Do you want to just explain a little bit about birthday cuddles while people are having a think? Because I think that's the first time we've really talked about that at all this morning. So it might be nice to just explain what you mean by that.
Yeah, so really is to, once the baby's, as we can see in the normal settings, when you have a healthy baby born, the first thing it has is has contact with mum and dad on skin to skin. For the preterm babies, it's slightly, this skin to skin is slightly delayed. And when we see historically that the first cuddle, kangaroo care cuddle, some of the babies only get in a neonatal unit, and sometimes the first cuddles the baby get is when the baby is being palliated or moved into comfort care. We know that not all preterm babies survive, and some of the neonatal preterm baby course can be really stormy, and therefore if we can facilitate some sort of normality for parents, a mum and dad, to have that first contact and cuddle in the delivery room, that sometimes is the only positive thing that they have from the neonatal experience, and something that we then encourage for them to take pictures and videos, so they have a memory in the long term. And particularly, you know, we've had this week or last week, we had a story that really resonates closely with the Paul Clark's publication about the birthday cuddles, and something that people in Evelina Hospital are doing as well is that we've had a mother who delivered the baby preterm, and team was able to support the birthday cuddles, and they had a 4-minute long cuddle, and this is a baby born at 23+5, I think, or 24-week gestation with a birth weight around 500 grams. And thereafter, mum was taken for a C-section under GA, and the next time she saw the baby was when we needed to withdraw intensive care treatment because it wasn't in baby's favour to continue intensive care. And if this mum would have not had that first initial cuddle, she only would have remembered her baby as this awful probably experience when we withdraw the care and tell all these things that we can't do anything for her baby. So having some sort of normality and a contact with the baby, it's really, really important, and it helps with their mental health and depression, and it also helps with the breastfeeding rates as well. So I think it's really important for all of the babies to facilitate and for team to be trained how to provide that. Thank you.
Thank you, Anda. I think you put that very eloquently. I realise that it's past, and I think we got quite a short break. So I appreciate people may need to hop off and get some lunch. I'm going to do the summary at the end of the day because I think it would be nice to summarise everything for the end of the day. So please, can everyone have a 15-minute break? But I really appreciate it if you're back very shortly at 1:45, very sharply at 1:45. Thank you very much.
Larry, can I just say, just for when you're having your tea break, do me a huge favour for Rebecca and myself and the wider team. And Tara will pop the link to the feedback form in the chat. And if you would help us with your feedback, it will help us going forward with more shared learning events with our colleagues at Wessex and at KSF.
Where do you want people to put this feedback?
Tara will pop the link in the chat, and all you need to do is open up the link and crack on.
Okay.
Great.
So if everyone can also do that, a tough ask when you've got to nip to the loo and get your lunch as well. But we should all do our best to do that. And I'll see you all at 1:45. Thank you to all the speakers this morning. It was absolutely fantastic. And thank you to everyone for listening. Bye-bye.
Great. Emma, can I just, can you remind the speakers just that I will come on camera 1 minute. Actually, Rebecca might do it for the afternoon. 1 minute. Rebecca will do it. Perfect for Wessex. Lovely. Tara, are you on? Tara, can you pop the questionnaire, the feedback form in the chat for me?
I've done it.
Okay, so I just want to encourage people to
yeah, it's in there. I popped it in just before we went on break.
Great, thank you, Tara.
Emma, I'm still munching a bag of crisps, but if there's no questions at the end of each session, I'll just pop on in case you want me to ask a question. But please feel free to, ask a question yourself if you want to. But I'm happy to do that if that helps.
Yeah, fantastic. Thank you.
And Emma, just to say, Lambry is having network and Wi-Fi and all sorts of issues. She's joining from her phone.
Right.
So we'll just have to see how it goes.
I think we'll just wait another 2 minutes if everyone's starting to come back. Okay, I'm making that 1:45, so I'm hoping that everybody had an opportunity to grab tea and coffee, a quick break. Welcome back. Thank you once again for joining us. I'm going to take you through the rest of the sessions. Just to remind the speakers that Rebecca will pop up about a minute before. So at 9 minutes, about a minute before the end, to enable some questions at the end of each of the speakers. So I would love to introduce Lindsay Sunderland for her speech on the preterm perinatal optimisation care pathway. So Marie's a senior advanced neonatal nurse practitioner at Poole Hospital, UHD, and has been since 2005. She has developed a special interest in caring for neonates born to women with mental health problems and quality improvement. Marie has completed a doctorate in advanced clinical practice, as well as postgraduate programs in neonatal studies and advanced clinical practice. She's currently working on QI projects related to the optimisation of the preterm infant. Welcome, Marie.
Thank you very much. As was said, I work in Poole. I'm one of the nurse practitioners there, and Poole is a level 2 unit. Next slide, please. So as a team in Poole, we decided to work on the 7 elements that are supported by the BAPM toolkit as a package of care. Whenever you're looking at any areas of quality improvement, baseline data is important. So I went and looked back at those 7 elements for 2021 in our unit. I'm just going to go through the data and the challenges we had achieving that, and then a quick look at a couple of our QI projects that we're planning for 2022, which shows the importance of MTT working across maternity, neonates, and also the anaesthetic team. Next slide, please. So in Poole, when we first of all look at the right place for gestation for birth, we know that really improves mortality and morbidity, and the target is 85% for those less than 27 weeks, or if there's twins, it's less than 28 weeks or less than 800 grams. These babies all should be born in a tertiary unit. So as a network in Wessex, they piloted a scheme called Cotline to optimise this, and this was such a success they rolled it out last summer. So for Paul, we did have 2 babies that were born in Paul less than 27 weeks. However, one was concealed pregnancy that was born at, that came into A&E at 8 centimetres. But usually we have about one baby per year. The only problem with this is we can count the babies that come into Paul, but there's no central data that I can extract that say about the babies that are actually optimised and moved along the pathway correctly. So whether there's any sort of central data that we can get as a network, that would be useful. Next slide, please. So the next element is antenatal steroids. So that reduces the risk of morbidity and death. Yes, in the less than 34 weekers. Ideally, this needs to be given within 7 days, and that kind of links in with what was said earlier about the QUIP app. The NNAP data target is 85% for those less than 34 weeks. And in Pool, we achieve at least 1 dose in 91% of the less than 34 weekers. So really good. But actually, when you do a deep dive on the data for a complete course, i.e. 2 doses, sometimes the second dose is given 30 minutes before delivery, or it's outside that 7 days of before birth because of preterm births settle or preterm labours settle, and then obviously can re-establish at some point later. So a good target, or it's a good number, but just a sort of a deep dive into the data around that. Next slide, please. So this just shows how a run chart of how we did with the antenatal steroids. Next slide, please. So the next element is relating to a project called Precept. So that's magnesium sulfate to reduce the risk of cerebral palsy. The national target is 85%. And we actually, that's for less than 30 weekers and who are within 24 hours of delivering. We actually give it up to 33 plus 6 weeks because there's still some benefit to giving mag sulfate in relation to cerebral palsy reduction. And we embedded this in January 2019 as part of a project. Currently for 2021, those less than 30 weeks, 76.5% of those admitting to our NICU had received some magnesium sulfate, and it's still 64% in the less than 34 weekers. So again, looking at the data, a deep dive where we can find some improvements. The reasons for not giving it was that the deliveries were imminent or it wasn't offered, and this is in the less than 34 week population. So again, a little bit of information to take back to improve any quality improvement, and that has been fed back to my maternity lead on Precept, who I work with, and to see whether there's any places where we can make any improvements on that. Is it an education? Is it a timing thing? Next slide, please. And then we can see from this graph that at the start of the year, for some reason, we weren't doing so well with remembering to give mag sulfate, but by the end of the year, we'd improved that greatly. Next slide, please. So the next aspect of that package is interpartum antibiotics. And the target is to give every woman, in preterm labour, less than 34 weeks, some interpartum antibiotics. So more than 4 hours before birth has been found to reduce the risk of GBS sepsis greatly. This is a really difficult data to extract. We had Medway, and our labour notes are physical notes, and trying to find whether interpartum antibiotics to be given was really challenging. You had to go for the narratives in the data, in the notes on the systems. I could say that Prom and Prems did get antibiotics, and it should be that sections would get antibiotics, but that was not always documented. So on the basis of the antibiotics I found, I could say that 73% of them had antibiotics who were less than 34 weeks. But we're going over to Badgernet, maternity Badgernet this week, and whether we can find it's a better way to gather that data, because it was really challenging. So hopefully in the future we'll get a better idea where we're at with that. Next slide, please. So then we come on to the postnatal bits of the package. So we've talked a lot today about deferred clamping and its benefit, and it's supported by the NLS guidance. And we've had a guideline since February 2020, which Donna in Southampton kindly gave us Southampton's copy, and we just used that as a basis for where we went in pool. And we do that as standard for all babies, even up to term babies. Next slide, please. But when we look at the babies that are the preterm babies, it's still only 41% of our babies that are less than 30 weeks and less than 34 weeks that actually get delayed cord clamping. And we looked at where their place of delivery was. 70% of our babies are born in theatre, but it actually doesn't make any difference as to whether they get delayed cord clamping or not. And the most common reason for that was that the baby needed resuscitation. So again, gives us an insight into where we can make some quality improvement measures. Next slide, please. Normothermia is the next element, and we've done a lot of work with this as part of the ATTAIN project for term babies, and so that's fairly well embedded, but just making sure that any quality improvement that you've already done is still being maintained. So when we looked specifically, this target relates to less than 32 weekers, and we looked at that and there was some room for improvement. So with that, it's been highlighted at a journal club. There's been some work amongst the nursing staff about a temperature champion. And we're sharing that with the maternity colleagues as well. So hopefully we might see a little bit of a pickup from that. And it is mentioned when we have governance meetings as well. Next slide, please. And just to make sure that we weren't causing a balancing, so looking at balancing measures and making sure that if we did delay cord clamping, we weren't making the babies cold, and no, we weren't. Next slide, please. And then the final element is maternity breast milk. So we know that that reduces neck infections and supports growth and development. So there was a target that they should have EBM by 6 hours if they're less than 34 weeks. And the BFI update is that mums should express ideally by 2 hours of age, because that's the most successful time frame for establishing lactation. When we looked at our babies, 97% of the babies less than 34 weeks did get breast milk at some stage in their NICU stay, but only 13% have it in the first 6 hours. So again, some room for improvement. Next slide, please. So we've got two projects for this year. We decided to work on delayed cord clamping specifically for the preterm babies. We do lo-fi delayed cord clamping for preterm babies, but obviously if they need resuscitation, then that interrupts that. So we're going to trial the Life Start machine and see if that gets around the need to cut the cord for resuscitation. This is still in its infancy, waiting for equipment at the moment, but the sim team are going to run MDDT sims in order to facilitate using it in theatre. We're going to start in theatres because that's where 70% of our preterm babies are delivered. We'll look at process mapping, and obviously we'll then collect data and feed that back. Next slide, please. And then our other one we're planning on doing, which we're a bit further ahead with, is early breast milk. So I did a deep dive of the data. We pulled some notes for 6 months and looked at when we gave breast milk and why, and it was delayed or other reasons. Again, it's not very easy to find on Badgernet. It's part of a narrative mostly, especially if it's involving skin to skin as well, which we're going to look at. We already had a great QI idea of using Colostrum Bags. So this is a fabric bag which has got all the things you need for that early expressing. And we've got a really excited, really enthusiastic team of champions that are really involved in early infant feeding, and they work alongside the maternity infant feed lead as well. So we're doing a process map, looking at the antenatal aspects where we can improve conversations with the parents, the mum rather, show them how to hand express antenatally. We're going to get the antenatal staff involved, and then the NICU infant feeding team are going to take that forward. We're doing some training. The infant feeding champions are doing the e-learning for health module, and then we're going to do a nugget video, which we're nearly finished for staff, and then we're going to launch that in the middle of April, having done 2 weeks of intensive training around it. Then release it, do some data collection, and then obviously see where we're at with that after through going through PDSA cycles. And then we'll like any quality improvement thing, it's important that you highlight it and keep that momentum going. So when there are key breastfeeding days throughout the year, we're going to just raise the awareness of this again. And we're hoping that it'll have a ripple effect, not just on the preterm population, but across the term population as well. And then as a separate QI, we're hoping to piggyback delivery room cuddles onto the use of the Lifestart and the early breast milk as well. Next slide, please. So this is just the contents of our colostrum bag at the moment. So just some lovely hearts to go into the cot, so they can get the smell of the mum and the baby can get that as well. Thank you.
Thank you ever so much, Marie. That was amazing to hear, and from a parent's perspective as well. I know myself that it took more than a day at 31 weeks for me to get my milk in, which is one of the reasons why I'm so passionate about those birthday day huggles. I like that concept. So thank you very much for that. Can I ask anybody to raise their hands if they have any questions for Marie? Eileen.
Hi, thank you. That was fantastic. Thank you for doing that presentation. Can I just ask you, so we heard earlier from Lawrence about the pressures that maternity services are under, and various national concerns and staffing and COVID and all the rest of it. My experience is working with the teams across the Oxford HSN footprint is that although staff are under a lot of stress and a lot of pressure, 100% the feedback is that the quality improvement work that we're doing with the teams around this particular pathway is a source of great joy, and they take a lot of happiness from it, and it inspires them. Is that your experience as well? Because I think sometimes teams are, there's a worry that, oh gosh, I can't ask people to do any more.
Yeah, I would say, especially with the breast milk, actually, the team were already together, and they just needed someone to light that spark and to give them a framework and to drive them forward. They're all really excited about introducing this project. They're all buying in. They've all got their little things that they're good at. So the people have really stepped up to do the video. I'm doing a little bit, someone else is doing a little bit about expressing. Someone's talking through the colostrum bag, and we're going to edit that together. Whereas other people, they come from a paediatric background. So one of our things that we do after we've done this initial bit is they'd like to do some outreach teaching to the paediatric unit, because obviously we have babies come into there, and they would like to share that. So they feel more comfortable doing that bit. So yes, they're all really excited about that. The delayed core clamping, we've already been doing it. Everybody sees, they know the benefit of it, but I think it's going to be quite a big change if we're going to reorganise theatre in some way. So that will be a much more challenging, I think, to get that sort of buy-in, to know that, and also for balancing measures, haven't we? I don't want to, we want the best for the baby, but we don't want to compromise what the anaesthetist is doing. So I think that, so I think the importance of SIMS there would be, it's important, and get everybody on board that's involved. But yeah, I would say, I've just finished a professional nurse advocate course, and part of that is everybody, they emphasise the benefit of quality improvement, even at a small level, to increase staff well-being. And so I'm coming with that head as well, and I can see that people want to make a difference. They are exhausted, I'm not saying they're not, but they want to make a difference, and they don't realise that they have that permission. So it's about empowering people to think, yes, I can make that difference, I can do something.
Amazing, thank you so much.
And I can see Ellery's got her hand up as well.
Hi Marie, great to hear all the fantastic things you're doing. I really appreciate that. Managing several strands and the challenges around the data can also be quite difficult, can't they? I just wondered whether you had got some very objective measures of whether to carry on doing your cord clamping or not, because when people are less secure about and are changing, sometimes you have to have very clear objective measures that you're looking at to decide whether resuscitation is needed or not. So I just wondered what you were using to do that, because it sounded like there was quite a significant amount where it was felt that resuscitation was needed, therefore you couldn't do it. And it would be really interesting to know what the parameters are to decide that they do need resuscitation now rather than waiting the minute.
So it tends to be that we don't scrub up for the sections. We're at the resuscitaire, so it's left to the obstetrician to do the initial swaddling and to feel the heart rate. We were thinking about theatres in a section, so we are obviously looking over, but we're not right there. So if the obstetrician's worried about a bleed or a placenta coming away, then they will do that. They look to us. We obviously start the clock. We're quite close to them. They look to us for confirmation that we're happy to continue. If we've got preparation of a really preterm baby, we had one recently where we had a 28-weeker, and there was obviously a before delivery conversation about this is something we would like to do. We made sure that the environment was warm. We didn't do any resuscitation whilst the baby was having the delay cord clamping. We don't have the facilities for that. The resuscitator currently is too far away, but we were able to keep the baby warm and allow that 1 minute of delay cord clamping and allow the baby to transition in that time. See, Donna just popped up there about clear guidelines. So yes, we do have that in the guideline. So we would revisit that once we see whether the Life Start is the thing for us or not. And then we can confirm that this is the parameters. And especially if we're all scrubbed and we're right next to the baby, we'll make that decision then.
Yeah, I think it's a good point around having somebody neonatal scrubbed into theatre, because it's quite a hard decision for the obstetrician to make. Yeah. Kind of looking after many other things, aren't they?
Donna?
So I was just going to chime in from our experience. So we've been doing that idea. So basically really clear guidance. If the heart rate is good, then DCC happens. If the heart rate is slowing or is not present, then we cut the cord and move to the resuscitaire, or if there's problems with the placental integrity. But we've just started in Southampton scrubbing up as routine. And so I did it last night at 3 o'clock in the morning. The registrar scrubbed up for a 650-gram baby. We couldn't do DCC because the placenta came away before the baby did. But the fact that she was there could help put the baby in the plastic bag, could assess the baby. We haven't quite got to the point of giving respiratory support with the cord intact, and now I might be changing my mind about that anyway. But certainly I think having someone scrubbed up to assess the baby from a neonatal perspective will really help us get more DCC in those equivocal cases where we're not quite sure whether to or not. And I think that will just give us the confidence to give it a go and wait a bit longer.
Thank you. I think we'll give that a go, actually. I think that's a really good point, and I will put that into the plan. Thank you.
No, thank you. I can't see any other hands, so I thank you once again, Marie, and I will move swiftly in the interest of time to our next speaker. So, have we got Lambury? I know that Lambury's having some problems with her connection, so
Hi, I am here.
Hello, are you good, Lambury?
Yes, I'm very well, thank you. So despite my best efforts, unfortunately, I have been unable to log into a computer with Teams on. So I am on my phone, so I apologize. I hope you can hear me.
Yes, and can I just introduce you? So Lambury is going to talk to us today about the neonatal elements of the optimization of the preterm infant and the research evidence. And Lambury is an acting neonatal consultant at UHS and has a special interest in education. I've had the privilege of working with her, and she's lovely to work with. Lambury is the Neonatal Transformation Fellow for the Thames Valley and Wessex Neonatal ODN and is leading the implementation on several projects in our network: pulse oximetry screening, CFM in Wessex, and the BAPN framework on extreme preterm birth. Lambury is also part of the MatNeo SIP, working with maternity and neonatal leads in Wessex to promote and support the optimisation of the preterm infant, working with Eileen to produce sim material for preterm birth.
Thank you very
much, Lambury.
Have you got my slides, please? Excellent, thank you. Okay, so today I have been tasked to talk through the neonatal elements of the optimization of the preterm infants and what the benefits of those are. Next slide, please. So as we know, the NHS long-term plan and why we're doing all of this work is to reduce newborn brain injury and death by 50% by 2025. And we also know that prematurity is the leading cause of cerebral palsy and child mortality. Next slide, please. So just a question for you, first of all. Is your unit implementing or thinking of implementing the elements of Preterm for the optimization of the preterm infant? Yes, no, or unsure, and you can put your answers in the chat box, please. Thank you. Okay, excellent. So we have, I can see so far that we have 52 units that have, or 52 responses that have responded yes, 9% that have responded no, and 43% that are still unsure that we're hoping to convince to move towards Preterm today. Excellent, thank you. Next slide, please. Okay, so I'm not really sure whether you can see this very well, but this is the Embrace report that was published in 2021, and it shows the deaths of the neonatal deaths of babies in 2018 in comparison to 2013. And as you can see, almost 3/4 of the babies who died were born before 37 weeks of gestation, which is the reason why we are gathered here today and in several different forums to optimize the care of babies born preterm. Next slide, please. So preterm optimization. So we know it's important, and we know that getting things right for preterm babies has lasting impacts on their future outcomes, both in terms of mortality and morbidity. And we have been working on this for years with more emerging evidence and more measures and outcomes that are both nationally, regionally, and departmentally. Next slide, please. So what toolkits are available to us? You can see that we have got the BAPAM optimization toolkit and the Preterm that we have been talking about. And today I want to stress that they're essentially the same thing, and Preterm is just an extension of the BAPAM toolkit. So in the next couple of slides, we will go through the differences and the things that are the same. Next slide, please. So the BAPAM approach consists of 5 toolkits that have been developed to support and support the improvement work that is going on. It includes the antenatal optimization, normothermia, optimal cord management, which we have been hearing today, early breast milk, and the QIP app. Next slide, please. And now the Preterm approach has all the things that the BAPAM toolkit has, and it has got a few more things, which include caffeine. Oh, I'm sorry. Volume guarantee ventilation. I'm sorry, I have lost my elements. Probiotics and prophylactic hydrocortisone. Next slide, please. So you can see the differences there, as we've spoken about, and that are those circled in red. And the quick PAP, which is different in BAPAM in terms of differences from the BAPAM point of view instead of the Preterm. Next slide, please. So today we're going to talk about the interventions for the optimization of the preterm baby in the postnatal period. And we have already heard about the antenatal and the immediate perinatal period. We will talk about early breast milk, caffeine, volume guarantee, ventilation, probiotics, and prophylactic hydrocortisone. Next slide, please. So early maternal breast milk. This is a UNICEF UK BFI standard, and it's also an NNAP standard. And so babies born under 32 weeks of gestation receive their own mother's milk by day 14 of life. That's the first outcome. And the second outcome is, does a baby born less than 32 weeks of gestation have their own mother's breast milk at discharge to home from the neonatal unit. And that says for 80% of babies born under 32 weeks that should receive at least some of their mother's breast milk. So we all know the benefits of breast milk, and I'm just briefly going to mention some of them. We know that it reduces the risk of NEC, it reduces the risk, the rate of ROP and late onset sepsis. Looking at more long-term outcomes, there are fewer rehospitalizations in the first year of life, and it shows to increase the IQ by 5.9%. We know that even tiny amounts of expressed breast milk by mouth for mouth care can be very beneficial to babies born extremely preterm and can decrease the risk of ventilator-associated pneumonia. And even donor breast milk is more is superior to having no breast milk at all and having formula instead. Next slide, please. This is just some of the references that you can go back and have a look at when you look at the slides, if that's what you wish to do. Next slide, please. So we're going to talk about a little bit about mechanical ventilation in preterm babies. So we know that non-invasive ventilation is the preferred method. For example, CPAP in babies born preterm birth and preterm. But we also know that some of our babies, especially the ones that are born extremely preterm, will require to have some sort of invasive ventilation and to manage the severe RDS. We know that pressure-limited ventilation delivers pressure type ventilation, which can lead to both barotrauma and volutrauma in babies, because it can deliver variable amounts of volume to those lungs that are very fragile and underdeveloped. We know that there's vast research that volume guarantee ventilation allows effective control of tidal volumes, and it reduces barotrauma and volutrauma, and it increases the rate of successful extubation. Next slide, please. So just a little bit about RDS and BPD. Infant RDS occurs in approximately 7% of all preterm babies. We know that about 60% of babies that are born under a kilo develop bronchopulmonary dysplasia with an oxygen dependency at 36 weeks of gestation. There is a high risk of poor long-term outcomes with babies that have BPD and with high mortality rates at 2 to 3 years of age. And we know that this can cause a great burden to society for babies born extremely preterm that survive. Next slide, please. This is just an infographic to show that tidal volume ventilation can reduce IVH by half. It can lead to the decreased risk of pneumothorax by 1/3, and it can also lead to less hypocarbia, so less amount of CO2 being excreted by the baby by half. Next slide, please. Again, these are some of the references and that you can go back to and refer to. Next slide, please. So let's talk about caffeine. So it's recommended that we give caffeine to babies that are born less than 30 weeks of gestation or less than 1,500 grams. And it's one of the top 5 medicines that we use in neonatal intensive care. We know that it has numerous positive effects on the immature organs, and it helps them establish regular breathing, and it prevents apnea of prematurity. It protects their immature brain. It reduces death and disability and cerebral palsy, as shown in the CAP trial back in 2007. It also improves cardiac function. And the dose that you can see is on the right-hand side is the ones that we normally use on our neonatal units, which is a 20 milligram per kilo IV bolus to begin with, followed by a 5 to 10 milligrams per kilo daily dose. Next slide, please. So this is an article that was published in 2020, and it essentially shows where we are in 2020. in terms of caffeine. We can say that caffeine is the current drug of choice to prevent and treat apnea of prematurity, and it reduces the need of mechanical ventilation. It enhances the success of extubation. And babies that are treated with caffeine have lower rates of chronic lung disease, IVH, and PDA. It can also have positive long-term outcomes on pulmonary function and neurodevelopment. So it has also highlighted that there's no commonly agreed standardized protocol for the dosing and the timing for caffeine. But the current practice that we have, which is 20 milligrams per kilo loading dose, followed by 5 to 10 milligrams per kilo daily maintenance, is considered effective and a safe dose. Next slide, please. So this was a post-hoc subgroup analysis of the CAP trial, which suggested a higher increase in BPD rate, which was 52% in those with early treatment versus a 23% if started after day 3. We know that caffeine is in the European consensus guidelines for the management of neonatal RDS, and they actually emphasize the role of the timing of caffeine, suggesting that the earlier treatment is associated with an increased benefit. It's also in the NICE guidelines, which recommend the use of caffeine from after initial stabilization. And there's several studies in the 3 systematic reviews of early versus late caffeine that summarize actually the results of studies so far showed the vast benefit of caffeine in reducing rates of BPD and need for PDA treatment and brain injury. Next slide, please. So before you have your coffee after resuscitating and stabilizing a preterm infant, make sure that they have theirs. Next slide, please. So we're going to talk a little bit about prophylactic postnatal hydrocortisone. And again, this is tackling BPD, which is a major morbidity of babies born preterm. And it has, with increasing babies born preterm, and with the fact that we have babies born extremely preterm as low as 22 weeks of gestation, BPD has not decreased over time, and we are finding that we need to find ways of managing and improving the outcomes of those babies. Previous research has shown that high doses of steroids resulted in actually short-term improvement of the survival, but it had unacceptable long-term effects such as cerebral palsy. Earlier studies showed that early dose of hydrocortisone for 10 to 15 days was associated with increased survival without BPD before discharge, and it did have a reduction rate in death. But we do need to be mindful of the fact that we have an increased risk of spontaneous GI perforation and increased risk of late onset sepsis. So despite all this, there's no adverse effects for death for postnatal hydrocortisone or 2-year neurodevelopmental outcomes that has been shown. Next slide, please. So we're going to talk a little bit about the Premilog study, which was a multi-center RCT study that was done in 21 French tertiary neonatal units in 2016. It was done on babies under 28 weeks of gestation, and they were randomized to receive 10 days of low-dose hydrocortisone or placebo, with the primary outcome survival without BPD at 36 weeks. And they had lots of secondary outcomes, including looking at the long-term effects and some potential severe potential complications that could potentially be related to hydrocortisone treatment, such as pneumothorax, pulmonary hemorrhage, late onset sepsis, NEC, GI perforation, and severe brain injury. This big trial showed that low-dose the prophylactic hydrocortisone significantly actually improved the rate of survival without BPD at 36 weeks of babies born extremely preterm, but it also reduced the need for PDA ligation. It did not show a significant difference in the other clinically important outcomes between the groups. Next slide, please. So following the Premilog study, they did an exploratory secondary analysis and they looked at neurodevelopmental outcomes of those babies at 2 years of age. And it demonstrated that a low dose hydrocortisone was not associated with statistically significant difference at their developmental outcomes at 2 years of age. Next slide, please. So this is a protocol that Preterm uses. To administer low dose hydrocortisone to all infants under 28 weeks of gestation. It is recommended by NICE, and we know that it prevents PPD, and it's got no evidence that it reduces mortality at discharge. Next slide, please. So we're going to talk a little bit about probiotics and what they are. They're live microbial supplements that colonize the gut and provide benefits to the host. And what they do is they influence the bacterial colonization of the neonatal gut. We know that the premature gut is altered by several factors, such as being born early, antibiotic use, reduced exposure to maternal microflora, and that abnormal colonization can lead to increased risk of NEC. So probiotics are one way to encourage the gut to build good bacteria and good flora. Next slide, please.
Lambry, sorry to interrupt. We're just conscious of time, so
yeah, sure.
I think you can see us, can you?
I've only got a couple of more slides left.
Okay, thank you.
Okay, so probiotics are supported by BAPAM and also the European Society, also ESPGHAN. And you can see in the Preterm bundle if you want, and they use a specific one called Infloforan, and to be given to babies born under 32 weeks of gestation or under 1,500 grams, and to continue until at least 34 weeks of gestation. There is lack of evidence, and there's contradicting evidence about their use, but especially regarding the dosing and the frequency. But there has been extensive research around which strains to use. Next slide, please. So things that we actually do know is that they may reduce the rate of NEC, they may improve feed tolerance, and they may reduce sepsis, but it also may induce probiotic sepsis in some babies, so we need to be mindful. Next slide, please. What we don't know is which strain, which dose, and when. Immediate in the first 24 hours or wait for breast milk colonization. So we do need further trials, and there's currently no agreement about when they should be used routinely. Next slide, please. So in the lack of, next slide, please. So I just summarized a little bit about the ESPGHAN position paper. Which basically summarized and said that we need to call for more improved quality control data. They provided advice on which specific strains might be potentially be useful and which should not be used. And they made a conditional recommendation of a couple of strains to use that may reduce the rate of NEC. Next slide, please. Okay, we'll skip this one. This is just more evidence. So we're coming to the end of our presentation, and what next? So think about your own practice and your own unit's data. And I would urge you to identify any areas of improvement so we can work together to optimize the outcomes of preterm babies. Thank you.
Thank you ever so much, Lambry. That was extremely interesting. And just in the interests of time, as we've run over slightly, could I ask anybody with questions for Lambry to pop those into the chat, and we will try and get Lambry to answer those. I'm going to move swiftly on to our next speaker, if that's okay. I would like to introduce Donna Winterbank-Scott. She is going to speak to us today about appreciative inquiry and optimization of the preterm infant. Donna is a consultant neonatologist at Southampton General Hospital, UHS, with a special interest in human factors. She has a special interest in quality improvement, and she's now working on elements of the Preterm optimization of the preterm infant bundle. Welcome, Donna.
Hello. You managed to find a picture of me. I forgot to send you one, so well done. I wasn't sure what was going to turn up, whether I was going to be Shrek or something. Anyway, so hi, thank you so much for letting me present today. I'm Donna, I'm one of the consultants from Southampton, and I do a lot of work on quality improvement teaching and human factors teaching and simulation and things like that. So I'm going to talk to you about something slightly different, which is not quite QI, but it's something slightly different called appreciative inquiry. So I don't know if anyone's come across this concept before. If you've been to one of our AHSN type meetings, you may have seen parts of this presentation before, so apologies if I'm repeating anything. Okay, first slide, please. So we're going to cover a little bit about what is appreciative inquiry in rapid depth, very, very shallow depth. So I'll just introduce the 5D model to you and give you a couple of practical ideas and tips that you might want to use to look at this topic in a slightly different way. Okay, next slide, please. So firstly, improvement approaches. I'm going to need you to tap to get each bit up. So the first improvement approach, if you can tap the slide, it should come up. So the first improvement approach is there is a problem, I must fix it. And I don't know if anyone's seen that little graphic on YouTube with the anesthesiologist and the orthopedic surgeon, but if you haven't, I suggest you watch it. It's absolutely hysterical. The next improvement approach is there's a problem and let's look at it a little bit more carefully and work out a solution. Sounds good? Yeah, why not? But we can go one better. We can do quality improvement. We can say, here's a system which contains issues. How can we improve the system so that issue is fixed? And that's a much better way of doing things. But there's also this appreciative inquiry idea, like saying, here's a system. What works in that system? What works already? What solutions already exist? Can we use those ideas and those solutions in a different way to solve other problems? So it's looking at the same system and the same issues, but twisting the situation around so you look at it from a different perspective. Lovely, next slide, please. So instead of looking at the hole that you've got and your big problem and going, oh my God, we've got to like fill this hole and we've got absolutely nothing. If you just turn around and look at the whole situation from a different perspective, you might find you've got all the resources and all the solutions already there. So hence this graph, this little diagram here. So it's really straightforward, appreciative inquiry. Appreciation is looking at the positives and things that work well. Inquiry is working out why it's working. And then improvement is the idea of putting those solutions to make positive change. So next slide, please. So this is the model that appreciative inquiry uses. It's called a 5D cycle. So the idea is you define, then discover, then dream, design, and then you get some destiny. I've no idea what happened to the rest of my slide there, but evidently there's a font missing because it's not supposed to go into all those funny symbols. Never mind. Next slide, please. And the idea is that you do all this discovery and dream and design, not focusing on the negatives, not focusing on what's gone wrong, but focusing on what's working and what's going right in your system. So next slide, please. So the first thing, defining, that's really quite straightforward. What's the topic? What are you looking for? What are you interested in? Originally, this wasn't in the model, but it was added later, I think, as this appreciative inquiry idea took hold. And you just need to sort of think about what you're looking at. So it's quite easy for us, optimization of the preterm infant. Okay, next slide, please. The next one is discover. So that's appreciating what is working in the system. So it's a little bit less data and numbers and graphs and spreadsheets, and a little bit more of sort of qualitative, talking to people, finding out how things work, looking for questions and answers and why things work some days and don't work other times. And there's a lot in the discovery section of this model about how you frame things, how you frame questions, and how you try and focus on the positives, because all of us just go, right, well, there's the problem and I know how to fix it. But actually, looking at it from a different direction is a lot harder. Next slide, please. So these are some of the examples of these sort of ways of framing things, like what's been a high point, or what makes things function well, or what wishes do you have? So this sort of language, it's sometimes a little bit sort of touchy-feely for some people, but when applied properly, it does work, I promise. Okay, next slide. So the next idea is to dream. So that's imagining what could be. So if you had the perfect hospital and the perfect department and the right number of staff, which I know is never going to happen, but imagine it could, it's what would you actually like to achieve? What have you achieved in the past and what can you build on? So you then kind of work out what your ideal would be. So next slide. Then you move on to designing that future, so determining what should be. And that is bringing together things like pathways and innovation ideas and copying bits of systems that work into bits of systems that don't, in order to create that dream that you've already set out. So next slide, please. And then once you've designed it, you've got to actually deliver it. So this is kind of the quality improvement PDSA cycle part of appreciative inquiry, where you either deliver or deploy, or you create the destiny, depending on how you want to use this model. So this is actually making those changes and seeing if it works. So the implementation or the do phase of a PDSA cycle, really. Lovely. Next slide, please. So why does it work? Okay, so there's these ridiculously long quotes that are all very, very highbrow. But if you go to the next slide, please, basically, it works because of these three things, which is a lot easier to explain than going through all those quotes. Firstly, it uses exnovation, which is a lovely term, but that's identifying solutions which already work, steal them and implement them somewhere else. Why not? Saves a bit of work. The next thing is positivity. And it's easier to generate enthusiasm when you're looking at positives, which is why things like implementing a delivery room cuddle that everybody feels really, really good about is so much easier than remembering to give a drug or remembering to tick a box on a sheet. If it's a positive thing, if it makes people feel happy, people are enthusiastic about doing it because it makes them feel better. The other thing with appreciative inquiry is it's less about firefighting, it's less about fixing everything that's going wrong and spending your entire working life looking at all of the problems. And actually you start realizing, oh, we do that quite well. That's good, brilliant. Okay, well, let's see if we can do the next thing better. So yeah, different way of framing things. Okay, next slide, please. So practical tips and tricks. So processes. I'm going to hit the slide again. Hopefully some text should come up. Hopefully, yes, wonderful. So what you can do, you could use appreciative inquiry to look at a system. Have a look what elements work. Why do they work? Can you copy that idea somewhere else? Is it that there is people in the system that have everything sorted and they're on the top of their game and they know how to do stuff? Why is it that their part of the system is working really well? What have they done? Do they have a spreadsheet where they keep track of things? Do they have a reminder? Do they have post-it notes all over their computer? Whatever it is, can you use it elsewhere? Automating processes improves reliability. So can you automate something else? And also, when you're looking at your processes, is there anything that's just dependent on one person or one factor? Can you put in some backup mechanisms so that if things get missed or go wrong, you've got some fail safes? That's coming from my human factors perspective. So next slide, please. This is an idea of looking at using appreciative inquiry to produce a pathway, so looking at a process. So this is Southampton's preterm delivery peri-prem process map from last year. So we thought, what would be the perfect pathway for a preterm baby to go through? So we just drew it. We imagined it, we drew it. This is all assuming that absolutely everything is perfect. We've got the right number of staff, we've got the right number of transport teams, the baby is an in utero transfer, which all happens at the right place. Everything works. But that's fine because we're in the dreaming phase, so that's okay. The implementation is slightly more difficult. Next slide, please. The other thing to do is in a process, when you're looking at appreciative inquiry, is to use carrots and sticks. So you know the old metaphor? So this is using bundles, carrots and sticks. So if you hit the next slide, hopefully some things should appear. There you go, carrot and a stick. So using this peri-prem passport, not only do you bundle things together, so you by ticking off what the baby's actually received on this passport, you don't forget things, because if you're really good at remembering to give the steroids, when you give the steroids and you tick it off on the sheet, you'll notice, oh, magnesium's next, better give the magnesium. So it's that idea of tagging some things that you don't do very well onto things that you do, so you don't forget. And this carrot and stick idea is that when you're ticking it off on the peri-parent passport, you've got this carrot going, yay, everyone loves to tick a box, don't they? That's a human nature thing. We want to say, we've done it, tick, achievement, gives you a little sense of satisfaction. So that's your carrot. Your stick is that if it's not possible on this form, you've got to justify why. So if you haven't given the steroids, you've got to write on this form, I forgot. But there might be a reasonable explanation why. It might be born before arrival, or there was no time, or DCC couldn't happen because the placenta detached before the baby. So it's absolutely fine to have a reason why, but by actually documenting it, that helps us get our process embedded and people to actually think about doing things and not take the lazy way out. Next slide, please. The other thing you can use appreciative inquiry for is looking at the team. So look at your quality improvement team, look at your maternity team who's working on peri-prem, who's working on BAPM, whatever. Work out who is good at various things and then use those skills to help your projects. So if you've got somebody who's really good with Excel and is a great data nerd, get them working on Excel. Don't get them like creating the posters that somebody else who's really arty can manage. The other thing to do is work out who's got things like power and influence within your department, because if you give those people the championship role for a change, they're going to get an awful lot more done than somebody who's less powerful or less influential or less persuasive. So utilise your team strengths. And if you really need to, find out who's the most scary and give them the job of implementing the change, because then nobody will dare disagree. Next slide, please. So mainly my suggestions and tips for using appreciative inquiry and quality improvement is just this positivity shift. So next slide, please. It's just about trying to work out what works and implement it elsewhere. Look for the positives in the system as well as the negatives. Try this approach when you're trying to investigate a situation. Ask appreciative inquiry style questions. See if you get a little bit more out of the person you're interviewing or the situation that you are exploring to get a deeper understanding of what works. And you probably work out what doesn't work as well. And understanding the strengths of your team and use positivity to motivate into getting changes incorporated. So next slide, please. I think that's the end. Yes, lovely. So final thoughts. I love this quote. When it rains, look for rainbows. When it's dark, look for stars. And that's kind of the entire point of appreciative inquiry. And I think tagging that along with a traditional quality improvement approach is really good, but also it's just really, really nice to look at things from a different perspective, especially when we've all had such a horrendous time over the last couple of years. So if you're struggling, try appreciative inquiry and it might just bring back some of that spark that we need. Thank you very much.
Thank you very much, Donna. That was amazing. I have heard of the concept and I've seen some great results like you say. So thank you for sharing that with us. We have come to the end of our speakers. I will ask about questions for Donna and I see Ellery's come back up so that we can have a bit of a summary and some final questions. Did anybody have any questions for Donna quickly before we do a summary? I can't see any hands up.
Donna, I just wanted to say I thought that was amazing. It's given me another way of sort of thinking about improvement work, and you presented it beautifully. The slides are gorgeous. I'm not so sure about your comment on giving the most scary person something to do. That could backfire on you really badly.
It can. That's a last resort. If you've tried the influence and you've tried the persuasion and you've still got a resistor out there, then that's the point at which you put your scary person on task. But yeah, I would certainly go with the persuasive and the nice, friendly paediatric neonatal approach first before you go down the surgical route. And if you will do it or else.
thank you, Donna. That was a great talk. I really, really enjoyed it. And I think it's a really good way to end off the day, actually, with such a positive and inspirational talk around how to do things in a slightly different way and how to think about things in a slightly different way. And I think we can all really gain a lot from that. So thank you very much to everybody who's come. I'm going to try and do a quick summary of the day, really partly to just highlight some of the excellent things that have come out today. It's been a very, very varied programme. So we started off with Lawrence, who was talking about reducing mortality without increasing morbidity, which I think was a very thought-provoking talk. And I think he very much was looking at the balance that if you try and make things as safe as possible from a stillbirth point of view, you are likely to significantly increase the risks of neonatal morbidity. And there's a very fine juggling act to be done to try and protect and reduce both the stillbirths and the infant, both death rate and morbidity rate going forwards. And I think he presented some very nice data around the optimal outcomes being shown for babies around 39 to 40 weeks, certainly in terms of their long-term development, IQ, need for special needs education. That all is at its most optimal around 39 to 40 weeks. So interventions done to reduce stillbirth need to really be very heavily targeted to try and ensure that only those babies that are most likely to benefit from that are actually put into that intervention group. And he then went on to talk about the trial that they've been doing around fetal growth restriction for several years, both in Oxford and actually in some of the other units in Thames Valley, and looking at those babies who have significant fetal growth restriction and the ability to not do some early intervention at 37 weeks for some of those babies. So I think that was a really useful, and I think other people wanted to find out a bit more about what that was all about. He also mentioned the QUIP app, which came up later on, about being a more specific variable, specifically looking at multiple continuous variables to try and give a more specific risk for each individual rather than single items with cut-offs. So it's much more about collecting variables, and the QUIP app was one of the good examples of that, which is now very much recommended in the Backing Toolkit. And he also talked about the Tommy's preeclampsia app. So there's more coming, I think, around how to use continuous variables from multiple sources and to create an individualized risk, which will help us to determine how to manage mothers and optimize both the maternal outcome and the baby's outcome. So I thought that was a really interesting start. We then went on to Catherine Hardy, who gave us a very interesting talk around the ambulance service perspective and some of the work, basically their workload, which seemed to be absolutely extraordinary. I was very astonished to find they've only got 163 ambulances usually on the road each day, and they're covering a very, very wide area. And they obviously have a very flexible approach and an incredibly well worked out triaging system to try and get mothers seen appropriately and the timelines for responses. And generally the response time for a more well mother is around 18 minutes, who is imminently about to deliver is around 18 minutes, is what they're looking at. And she then went on to talk about the training that they're trying to do for ambulance crews, and also some of the significant things for the ambulance crews in terms of the level of training that they've had, that feeling that this could be more scary for them, and the realities in terms of other human factors. You know, because it's so difficult and so scary, going to the nearest place is often what they would be very tempted to do. They recognise from some of the trauma work that sometimes it's better to take people much further and to go more miles with a patient. But I think that's something we very much haven't got to the bottom of in maternity care. And I think that's something that they will be looking to do in the future. So that was a very interesting talk. And and something and an area which I think there's more work that will be done over the next few years to try and make a much sort of better pathway for mothers who are at different risks. So I think that will be really good. We then came on to Emma's talk around involvement of parents in the network and the work that she's been doing with the Thames Valley and Wessex Parent Advisory Group to help really embed the parent voice into all areas of neonatal work. I think she really used that word co-creation for a lot of things that you're doing, so that the parents are really involved in absolutely everything. I also rather enjoyed her shoe analogy, because I do think, you know, why on earth would you ask the people that make the shoes whether they're right? You'd ask the people that are actually wearing them, and that's the really important part of getting parent involvement in this. And I think she really was very thoughtful about us trying to be more mindful about how parents are thinking and feeling, and making sure that we think about that as we're going through. And she also talked about all of the work that's being done with the ODN, both setting up the parent group, but also in terms of all of the levels of care that they are involved with, and all the different groups that are working in neonatal that they are involved with. And they're also been involved with job descriptions and getting in on interviews, and really trying to make sure that there's involvement with all the teams. And I think that's going to be it's a real credit, and I hope that other networks will also take inspiration from that. I think that's been absolutely fantastic. So where do we go then? I'm on to the next page now. So next we were on to Charles, and Charles was talking a little bit about the evidence around ventilation on the uncut cord. He asked us all a question at the beginning about whether we thought it was national guidance to do this, and I think about 2/3 of us thought it was in the national guidance. And I think he then showed us quite a lot of data about how good the evidence is for delayed cord clamping in preterm infants, and how well this works, and that it is probably even more beneficial than it is in the term infant. And he then went on to talk about perhaps not basing this on a time-based analogy, because at the moment this is very much a try and wait at least a minute, but that perhaps it should be, and there is some evidence to suggest that we should be doing this as a physiologically timed cord clamping. So making sure that the baby has started to breathe, possibly giving some respiratory support with that. He then went on to present some of the evidence for which has looked at ventilatory support, and certainly that evidence is not clear at the current time. And so I think one of the most, there were several other things that he talked about which I think were really important, one of which was the trigeminocardiac reflex, which is where if you put a face mask on a baby, you may induce that dive type reflex where the baby will go apneic in about 30 to 50% of cases, depending on how preterm they are. And I think that's really important that we remember that. So there are some issues with how you'll do your ventilatory strategy. So we certainly haven't got that sorted out. And he also described some of the difficulties with giving respiratory support that doctors and nurses have, and that we can actually make things a bit more difficult for the baby if we haven't got them right. We're not synchronized with the baby. We manage to obstruct the baby's airway sometimes when we're doing respiratory support. So there are definitely things that are not quite concluded with that. And so I think the overall message, which I thought was a very important message, was around the fact that we should be focusing and concentrating on getting the delayed cord clamping done in a simple fashion. We don't have to start with, get any sort of ventilator or resuscitation support. We just need to try and get the basics right and get the delayed cord clamping done. And that requires really good NDT working, but not a lot of equipment. So make it simpler. I think that was one of his messages. Then Anda gave us a very inspiring talk about what's been happening in Thames Valley regarding delayed cord clamping and the quality improvement project that they've been doing across Thames Valley. She also reminded everybody that there's a 30% reduction in death from doing delayed cord clamping, which I thought was a really important reminder that we need to get on with this and do it quickly. It also very significantly decreases IVHs and PVLs. So, and she talked about all the different ways that they'd done this in Thames Valley. So there was very much about education guidelines, having champions, knowing your baseline data, doing your PDSA cycles, encouraging each other by meeting up, and very much keeping the energy going with the project. And she demonstrated that across Thames Valley, the delayed cord clamping has changed from 26% to 60% across Thames Valley, which is a really important and useful addition, and will have had a significant impact on outcomes. So it's really important to do that. And she also then talked about where they're going forwards from here. So starting to use high flow therapy, which doesn't involve masks, but does give some additional respiratory support on the cord, and also the development of the birthday cuddle, and giving parents time at that very early stage to have some time with their baby, and that it might be extremely important, particularly when babies become much more unwell. It's maybe one of the few times that they have a very special moment with their baby just after they're born. So following that, we had a talk from Marie, who works in Pool, and was talking us about their optimization pathway in Pool, and they're looking at 7 different elements of care. So she was looking at the place of birth, antenatal steroids, magnesium sulfate, intrapartum antibiotics, delayed cord clamping, normothermia, and breast milk within 6 hours. And she talked to us about, you know, trying to get those measures objectively and collecting the data and some of the challenges associated with that. You can't get quality improvement to work if you don't have good data. So I think it was really, really helpful to talk about some of the challenges that they've had with that, and also to show us some of their run charts and some of the progress that they'd made, and to describe some of the excellent plans that they've now got to develop that further and to move forwards. And I think that's a really good example of what can happen in an individual unit, which was excellent. We then moved on to Lambry, who was talking to us about some of the postnatal period optimization things and the research behind that. So she was particularly looking at volume guarantee, the use of caffeine, probiotics, and the use of hydrocortisone. And she talked very much around the evidence base for all of those things and where we are with that. So certainly volume guarantee has been shown to significantly reduce BPD, IVH and pneumothorax rates, and is very much something that that should be being used now in all units, and units that aren't using this really need to try and move across to getting the volume guarantee mode of ventilation as their standard mode of ventilation for the preterm infants, which is what is recommended in NICE. Caffeine, she also talked about the CAP trial and also the later results from the post hoc analysis of the CAP trial. So there is good evidence for improvement in both respiratory and neurodevelopmental outcome, and those outcomes are improved if you give caffeine less than 3 days, so early caffeine compared with when you give it later. So I think there's she presented some very nice evidence for that, and if you want to go and look, you can see the evidence and where the papers are for that if you want to in the slides from her presentation. She also talked about postnatal prophylactic hydrocortisone given in the first 10 days to 2 weeks of life, also to look at reducing BPD and death. She also pointed out some very important reminders around the potential increase in spontaneous intestinal perforation, and which was really important. There's something else that she also pointed out. She might pop it in the chat for me because I can't read my writing. But she also talked about the Premilox study, which is a big French study, which first looked at this, which showed some very clear good outcomes, and certainly the short-term data from that were very good. And I think that's something certainly that that is being looked at, and is certainly part of the Preterm project. So I think there's probably further evidence to come around the early prophylactic hydrocortisone, certainly around some of these concerns with the later interest. Sorry, it was late onset sepsis was the other thing. So I think that was also very interesting. Where did we go from there? So we also did we go from there to our when we went to probiotics? Apologies, I didn't miss the probiotics out. And she talked about the current guidance, and the guidance has gone into SVGAN around the potential for this to reduce NEC and the current guidance around that. And then we finished off with a really interesting talk around appreciative inquiry, which is something that I'd sort of heard of but hadn't really had very much detail about. This very positive way of trying to look at approaching change and system improvement. And I thought it was really good. Donna described the model that how this is supposed to work, which is a sort of a 5D model around how to work. I particularly like the dream part of it, which was in the middle. I think we could all do with dreaming about the way we'd love things to really work to work if we had no barriers to making our care as good as possible. And then how you refine all of that to make something that will work. How you pinch ideas that have already worked from elsewhere and use them because they've worked well. And I also liked the way that she went about looking at how you use your staff well, always looking at what the positive, what people's best features are and how they best fit into the team to make something work really well. So I thought, and I thought her ending was really fantastic. Think positive. I think after 2 years of a pandemic and currently the awful situation going on in Eastern Europe, we really do all need to think positive and think of our babies in as positive a light as possible, and also our teams. So that is a summary, a quick summary of all of the things that have happened today, and that's what I took away from that. Eileen, should we leave the last word to you?
Oh, absolutely not. We've got 2 minutes left. So if there's anybody who's got a burning question that's going to irritate you for the whole evening, now's your chance to ask it. And I'm going to give you a couple of seconds. And just to point out that there's a few questions in the chat box, but while you're thinking about this, just a couple of things. I just wanted to say thank you to the wonderful chairs. This is the first time we've done this type of event, and our colleagues at Wessex, so Rebecca Savage and James and Tara here at the Oxford HSN have just been phenomenal with helping to put it together. And then, of course, all of the presenters, and Larry has done the most brilliant summary. Thank you, and that will go up with the recording. Just so grateful to everyone. I think you're all just fantastic, and we're just doing such brilliant work, and loved that positive message from Donna as well. I thought that's such a good thing to end on. I have done lots of tweeting. I've been trying to do some social media stuff. So if you have a look at the Oxford Patient Safety on Twitter, or Eileen on Twitter, you will see some of the slides and some of the key messages and some of your pictures on there. Tara, is there anything else, James?
A reminder to fill the feedback form in. I can see that some people have already done it, so great. Thank you very much for your feedback and your comments.
And we have everybody's email address, so we are going to make sure that we share the recording. We'll do that quite quickly so that you're not waiting for it. We'll go through the chat box and we'll do a summary of the questions if there's anything we haven't answered. We will send you out the analysis of the feedback, and we hope that this is going to be the first of many shared learning events working with Wessex and KSS. I think that's everything, Larry.
I think so. And thank
Rebecca?
you to everyone who stayed on the call. I think it's testament to how interested people were, that there's been a lot of people who've managed to stay on the call all the way through. So very well done to everybody, and keep going with all your important QI work.
That's it. Rebecca, anything finally from you? We're 1 minute over.
No, just to say a big thank you as well. I really appreciate all the hard work that Eileen's done to pull this together as well. So I think it's been an amazing event. Thank you to everyone that's managed to attend. And I will see as many of the Wessex team as possible on the 16th at our next kind of interim meeting. It'll be really great to chat through some of this further.
Okay, brilliant. So
I think
Tara,
Emma's also just got her hand up. Sorry.
yeah.
Yeah, just a final from me. It's been absolutely amazing chairing with Larry. It's been ages since I've seen you present, and I could listen to you all day. Thank you so much, Eileen, for your amazing support through this. But thank you all for letting me be part of this amazing event. I've learned so much, and from the bottom of my heart, from all of your PAG members, just thank you so much for everything you do day in and day out for our tiny or sick babies.
Thank you, everyone, and we'll let you all go. I know it's always very difficult to decide when to finish, but we'll let you all go. Bye-bye. Thank you.